How are you doing? The Traveler, how are you doing? Nikki, Conroy, how are you guys? Oh, let me try and send this out. I'm doing well. I'm doing well. Went to church today and it was a good day, I must say. Yeah. It was a good day. How about you? How was your day? Try to see if I can send out. I'm trying to share the link. Yeah. Hi, Anita, Annie. Welcome, welcome. Blacker. How are you guys doing? It is what time now? It's 8 o'clock for me. How about you guys? What time it is where you're at? Margie, welcome. 9 p.m. Okay, nice. Nice. Pin your goal for viewers. Let me notice it. Tired of that thing there. I don't know how to get my little thing down the bottom here, but anyways, I guess we will figure that part out someday. Winston, welcome, welcome. How are you? So tap the screen and share. Oh Lord, where is that? KK Mommy, welcome. How are you guys doing? If you don't mind, just go ahead and sharing the live for me as well. And like up the live as well. Thank you, thank you, thank you. Jayway 176, welcome. Samuel. What up, Sherry? Sherry Jamaica. Oh, as I talk about Sherry Jamaica, there was a Sherry who had texted me. Rosemary, welcome. How are you guys doing? Sherry, were you the one that texted me on my number? I was supposed to give you a text back. Oh, it's on the phone that I'm using. I was supposed to text you back, but I think that was at the time of my heading to my vacation. And totally forgot. I'm going to make sure I reach out to you just in case you have any questions. Or just to talk with you, because I did promise I was going to call you. Sasha Gay, welcome. Simone Khan, El Stiggy 89. I'm seeing you guys. I'm seeing you guys. How are you guys doing? All right. I wonder if my vision I get blurry or what. I know I'm due to change my glasses, but that's not until probably 2 months' time. Yeah, so how are you guys doing? I remember you can always go ahead and leave if you have a question that you want me to answer, feel free to go ahead and leave it there. And if you haven't followed us yet, remember to go ahead and follow me here. And you can also go onto my YT page at Think Nursing and follow me there as well. I will share the full length of the live, from TikTok here onto YT. So if it is 3 hours, it's going to be over on YT page that you can sit and just listen to. Marvin, I am doing good. How about you? Blessed Kia, welcome. Dwayne, Brenda. Yeah. You work today, Marvin? Remember, guys, just go ahead and to stop up the live. All right, you just need to just touch the screen multiple times. That's all. Should I put a live goal for you work every day? No, so that's not good. So when you get time for self-care. When you get time for self-care. What area you working again, Marvin? It's not nursing. It's not the health field. Yeah. Remember to go ahead and check out my videos that I posted here on YT. I will definitely, not YT, on TikTok here. I will definitely come through and, you know, answer some of you guys' questions or concerns regarding the videos that I posted, especially the one regarding, you know, the Adult Protective Services case there, whether or not we should report or not. It was reported, you know, but usually before I try to work with the family members as well, but I still go ahead and flag them. I still work with them in terms of giving them resources and all. And especially depending on how long the situation, you know, has been going on, then I tend to use that as a part of my assessment and decide, you know, if I'm just going to be jumping into that aspect of it. But I always try to give resources that the family members can work with before, you know, trying to play the hard ball with them. But it's our responsibility as healthcare professionals, as soon as we see, you know, any sign of like abuse, neglect, anything like that, then definitely it's our responsibility to go ahead and report. You can do it anonymously. You can do it online. Well, you really can't do it anonymously because, you know, they try to protect you, but they're going to still want some information from you. So the time when I did report it, I did went online and reported it because the wait time usually is pretty long. The wait time is usually pretty long with those cases. So I did went online, reported it, and you know, make sure you have your reference number, the ID number. You'll get a code for that, so you can always use it as reference and keep follow up on it. If they have additional questions for you, they will call you, and that was it. They call, and you can always give them any amount of information that you think is going to be, you know, beneficial for the case. If it is something that don't need follow-up, then usually they don't do anything about it afterwards. If it is something that definitely needs addressing, then they will definitely, you know, and then depending on, you know, how urgent it is, if it is something that needs intervention today, tomorrow, then they take that into consideration. If it is something that can wait for probably like a few days, like, you know, weeks, then. So they always try to call and make sure they get enough information regarding the situation, and then from there. All right. But in terms of, I know a lot of persons were asking about, you know, persons were asking about who was paying for basically the home health aid that is there, and that is provided by their Medicaid insurance. So when we do see patients, a lot of them, they have Medicaid, and so they are able to get certain, you know, services started for them. So they will get a home health nurse that will go in once or twice per week, depending on what's going on with them. They can also get a home health aide who will help out with, you know, just making sure that the home is clean and providing meals and all. But sometimes the home health aides who do all of those, like the washing, assist with washing and all, sometimes most of those patients don't have any relative with them. You have a lot of them that do have relatives, but most of the time those patients, family members will take responsibility for a lot of things, and they will just have the home health aide focus on the patient. But you have some who definitely don't want to do that. They will definitely make use of the home health aide as if they have, you know, the entire responsibility of the house. You understand? They're responsible for the entire house. So you'll find out that's the thing. But yeah, you have the insurance that will definitely go ahead and pay for certain amount of hours throughout the day. Usually the family members can decide how they want it. So for example, you have family members who do work, then they would say, okay, then we want them between, 10 and 3, or, whichever time they feel is best suitable for them. And that's most of the time during the week time, because on the weekends you have a lot of family members who are not working. So they will usually take care of them at that time. This situation, I don't know. It doesn't seem like most of the adults in the home are working. Like, it seems as though probably they're doing remote jobs, or it's just a case they're always available, it seems. But they are not that active in the patient's care. And that was just a concern for this family. But as I say, you have to always listen to whoever is with the patients a lot of time. So even though this would have been my second encounter with them, you could hear the frustration of your caregivers when you're interviewing the patient and talking with them, getting information from them. So that's why I always say, like, when I go in to see patients, I look around. I don't just focus on the patient. There's certain things in the environment that you're going to be using, you're assessing, to make sure that it's a part of your plan or your interventions. You get that information to come up with your diagnosis and all. Fire, thank you for that. You use it as a part of your, how you go about with managing your patient. So you listen to the patient, you assess them. You also go ahead and talk with your caregivers. You talk with, whoever is in the home, so you can have a better idea as to what is happening. Whenever you can, try to send away the caregiver for a few seconds and try to have an alone time with the patient. Because sometimes, they're very scared to talk about certain things. And most of the time, they'll still say no regarding if they feel as though, they're being neglected. They're not getting their food. They're not getting turned regularly, changed regularly. So if you can find the time to say, okay, then can you step away for a second so they can feel a little bit more comfortable, giving you some information, then try to do that. And then you have to, observe the patient's family, how they behave around the patient. Sometimes they don't give the patient a chance to talk. And not all the time these patients are confused. So it's important for you to go ahead and make sure you're assessing their mental status, how oriented they are. See what information they can remember, and you try to dig some information. Even if the relatives are giving you that information, I tell them, it's okay, the patient can talk. I'll get the information. If I don't feel comfortable with whatever the patient is saying, then I will ask them to kind of butt in. You understand? But always try to make sure that the patient is a part of, the care. Make sure they're giving you information so that they don't feel left out. Because after a while, you might realize that it's a family member answering every question. If they say, do you have headache? Are you having any headache? The relatives will answer and say, no, them not having any headache, when really and truly the patient over there probably nodding their head. So always just go ahead and find out from the patient as well. And even when they say the patient is confused, as I said, just make sure you're checking, because sometimes they say the patient is confused and you might be surprised to, what information the patient can remember. You ask them what holiday they celebrate in December, and they'll be able to tell you, even though they might tell you that, yeah, the patient is confused. You ask them who is the president before, like, so for example, you quote unquote use the black president. Some people remember who was before, or you say, certain things. You give them little clues, and they will definitely answer certain things. And then from there, you can always ask them questions, and then, based on your assessment and everything, you decide how you go about with that. Hi, Renee Thomas, welcome. Robert Martin. Fire, thank you for that. Blessed Kia, thank you for the like. Marvin, can you? I hope me say it good tonight, because I remember on the other live, we were having a problem with that. Right, Fire? So, Kian UK. All right. Hola, how are you doing? All right. So, definitely go ahead and just find out all of those informations from the patient, and then incorporate the same, the same questions you'll be asking the patient, you ask the relative as well if they notice anything that is concerning. And so that was just it. But as I say, if you suspect something, it's your responsibility to report it. If nothing comes out of it, it's not going to go against you. If it's a case where you fail to report it because you suspect it, you see that there is something going on and you fail to report it, then definitely that can come back to be a problem for you because you notice something and you never report it. It's no different from, you know, when you're in the hospital and a child come in the emergency room, you notice that, you know, they have certain kind of markings on their skin and you're suspecting that this one probably, you know, get burned by a cigarette and the fall, they might say that the patient fell from a bed, but yet still the patient had like a, you know, a hip fracture or something like that. The signs or the symptoms that the patient is having, because based on what you're seeing, it's not adding up to what the overall, you know, report of what the family members are giving. If you're suspecting that there is something else going on, then definitely go ahead and, you know, call, report, and give your, you know, what you're thinking, what you're seeing, and what the patient's relatives say, how the patient is acting in, you know, how the relatives are acting. And then you give that information, and then you have those persons who will go ahead and decide, okay, then is this something that is worth following up on, you know, and then from there. Yeah, so that's just it. So as I say, it's your responsibility to go ahead and report. It's my responsibility to go ahead and report. And it's the same thing. We're going to jump a little bit to, you know, when you're working with certain company, it's no different. If you realize that there are situations that are unethical, it's your responsibility to report. So not because they're nurse practitioners or not because they're doctors, you know, and you feel as though they are more senior than you are. If it is something that is worth reporting, you know, go ahead and report it because we are all, you know, mandated to be reporting certain things. So it can't be a case where only reporting patients because this is what is happening with them, patients and their loved one. No, if a doctor is doing something or a nurse practitioner is doing something, it's unethical, you know, it's just not right, you go ahead and report it because it is something that needs to be reported. So, you know, that's just it. Pretty Chinky. Welcome, TT. Thank you for the follow. Joseph Watson, hola. Fire, what you laugh about now? What you laughing about? Yeah, man. So go ahead and do all of those things and report them. Oh, let me add this flash goal. Because as we say, you know, TikTok is always telling you go ahead and do whatever. 3 gifters send rose to your flash in 15. All right, I don't really know this flash goal, but I'm going to pin it. I'm going to pin my flash goal. Oh, so I guess it wants you guys to go ahead and send me 3 roses if you feel the need to. All right. But yeah, definitely that's that on that part of the questions that you've been posting or the comments that you've been sharing. And then, you know, some people say that their day will come, the wicked they didn't face you because of shame. Elderly abuse should be treated the same as child abuse. Definitely. All right. So that's the thing, you know, and I agree with this comment from your herbalist, where she said that sometimes they're ashamed, that's the relatives, sometimes they're ashamed of the condition of the patient, especially because they're under their roof. And so they might not come out and face the nurse practitioner. And sometimes, you know, I talk about this one on my YT page where, you know, I went to this house and it was, you know, Miss Hattie Hattie coming through the door. You understand? And when you talk about Hattie Hattie, we're talking about, and this is not anything to, you know, like you're judging people, but then you're thinking about the fact that people are coming to your house and you have your relatives there that you're supposed to be taking care of as well. And some of us are just, you know, just not in the mood. We're not wanting to be caring for the patient. We're not caring for the house. The place is looking like a total hot mess. And when me tell you, say it was so disappointing, and I was just there standing looking like, you know, is this even real? Because this young lady walking out of her room smelling really good, you know. Smelling really nice with a Louis Vuitton bag, nice glasses. And when we go into the place, it's like, me have to go like this, you know. I rub my nose because the place not smell good. You understand? There was so much garbage all over me. I said, look at that. We are all young people. I'm not talking about, you know, I'm talking about probably like in the 20s, 30s, where you know that them have boyfriend, husband, them kind of stuff here. And I'm just wondering, how is it that we carry people to our homes, you know, in that situation, knowing that the home is not in a good condition, and then yet still we have our relatives there, it not look good. So make sure we're taking care of ourselves, not only of ourselves, but taking care of our relatives and the home. Make sure it's presentable and it represents you as well. You understand? You can't just be looking like $1 million girl, and then when you go to the house or you're stepping out of the house and behind you it look like, you know, a dollar. You know, make sure your place is like clean and it is welcoming for persons that are coming out. And as I say, not everywhere you go you're gonna find that the place is gonna be, you know, the best, but make it be presentable. Make the home be something that is welcoming, even if we consider you to be poor. You understand? Or you consider yourself to be poor, you don't have the resources or whatever it is. You can always take a little broom and sweep up, you know, when you eat, you take up your plate and put it in one place, the garbage bag full, you know, you take it and you put it one place, empty the garbage in the place, but you don't just leave everything there making it seem like it's a homeless, it's like a, you know, a garbage bin or a heap or whatever it is. Make sure the place just look good. You understand? So you don't have to have the fanciest of things, but try to just make it a little bit more cleaner for your relatives that are there and not making them feel as though them living in a slump or, you know, stuff like that. So that's just it. So that's one. So she's saying that. Okay, this one is not related to that comment. Yeah, but I noticed that, you know, you guys have been putting down your comments and your views on that one. All right, so somebody was saying, look here, speaking from experience, these family members don't care. And, you know, that's it. And what I realize is that a lot of times you find that you see the persons who say that they're caregivers and they are relatives, them not take care of the people, them. They don't take care of them. You understand? They do not take care of them. For me, they're the worst caregivers you can ever think about. You understand? Better you give strangers the opportunity to come and take care of your loved ones because they will do a better job than your loved one. In the meantime, I'm going to have you just go ahead and just stop up the live. You know, give it a few like. Let me just go and do something here for a second and then I'll be back in a few minutes. Oh, never mind that. Yeah. But, you know, definitely they are not always the best caregivers for the patient. All right, you have some of them that do an excellent job and you have some that are they're not.
I need the charger.
I will bring it. I said I will bring it.
Is on timeout.
It's there.
Here you go.
I will bring it.
Uh-oh. Good night, Diamond Heart. How are you? Jesha Romaine Johnson, welcome. Marvin, so you're still using your WhatsApp number? Yeah, man, all of my number them still at work, Marvin. You can always, yeah, so if you guys, you know, it's on my YT page, my WhatsApp number. If you want to go ahead, you can message me. And when I get a chance, I will... Yeah, so if you want to talk with me, if you have a question, concern, you know, you can always send a message, and when I get a chance, I'll respond to it. And only, you know, questions that is related to nursing, travel, and lifestyle, things like that, or if you just want to heal me up, I'm all right with that, okay? And then from there, but the number is there. You can feel free to reach out, because I know sometimes as nurses, you probably want somebody to talk to, and that's what my number is there for. It's more from a YT page where, you know, I have like a live, but you know, on YT it's a little bit different. So I try to have persons call in while I'm on the live. I would just kind of have a sit down and chat, just like what you can do on TikTok here. But TikTok is a little bit more, you know, easier to use. Let's just see. So yeah, definitely that number still works. All right, and then somebody was saying them to remember that, you know, they will get old as well, and they too, same thing are gonna happen to them children, neglect them. And that's one thing, you know, a lot of persons tend to be saying that it doesn't make sense you have a lot of children nowadays, because after a while they'll come back and do the same thing that, you know, some of these patients' relatives are doing to them. And me kind of understand from that side as well, but at the same time, we're not having children to say, come and take care of us. We're not having children for them to come back and take care of us. But at the same time, you know, when you do have one and two, the hope is that they will eventually come around and take care of you. You understand? Even without you saying that this is what you're doing. That is the hope, for them to be there for you. One of the saddest thing I notice is, you know, when I have patients, and this was most of the time in the hospital setting, and they're so sick and they don't have anybody visiting them. You understand? It's always just a sad situation, especially when they're on the last. You're hoping that at least somebody would be there advocating for them a little bit more, you know, giving that, you know, therapeutic touch. A lot of times they just want somebody to sit down and be there for them. But them not have it, you understand? How do I deal with that? It's so sad. As we say, you know, most of the time I just take the time and just spend with them. A lot of people don't talk about it, you know, but, you know, as nurses or healthcare persons who are working so closely with these persons, and you see what they're going through, hear what they're going through. When those patients are crying, you know, you're ball deep down, you know, and sometimes you're crying with them. You are crying with them at the bedside, knowing that whatever they're going through is something that is, you know, yes, the mute button active, active. My son come and, you know. But anyways, as me say, you know, a lot of times you sit down and you be talking with those patients, or they're going through their system, their situation, and you're crying with them. You understand? It's like you're there and you see what they're going through, you hear what they're going through. And you can't really do anything more than just spend the extra time and just, you know, be there for them. And sometimes you're in the room, and even though you want to kind of drag away from them because you have other patients to go and deal with, but sometimes you definitely have to do it, you know. You still have to do it, but you have to know how to do it. You understand? Because especially, just think about the patients that you have, the other patients that you have, and then see if you can spend the extra 10 minutes, 15 minutes, even though sometimes the patients will talk, cry, and it's like you're just stuck right there. Sometimes you don't know what to say, you don't know what to do, and you're just there, just listening. But, you know, as I say, I just stay there until I'm at a point where they finish. Sometimes I just want to vent a little bit. I just let them just talk, you understand? And then I'll just run and finish, catch up what I'm doing, and then come back in, just in case, you know, they wanted to say more. But it is very sad, especially when you hear that they say they don't have any children, they don't have any husband, or they're the last of their kind, you know, nobody else. Yeah, it's very touching. It's very touching, and it's just very sad. And as I say, you just have to spend that extra time and just be there for them. And even when you are going through your own situation, you still have to just woman it up, man it up, and just be there for the patients, because, you know, they're looking for you to just have that, you know, that side of you where you're listening, you show that you care, you know, be compassionate towards them, things like that. They're looking for it. And so you just have to be there in their time of need. You understand? Put away your little, you know, whatever is going on in your life, even though sometimes it is so much that you might be dealing with on a personal level. You have to just put away that, because you're in that zone. And so I always tell people, you know, nurses or healthcare workers, they are humans as well, but at the end of the day, sometimes people don't really think, you know, they don't look at us as that. Because every single time you go in, it's always, you have to be giving your best. And nothing is wrong with giving your best. But on those days when you are giving probably 80%, and 80% is the best of what you can give, you know, people don't understand that you might be going through something, and that's why you can only do the 80%. And yes, so we complain about it and make it seem as though, you know, it is not good enough. I mean, understand, say, yes, you want to give 100%, but we're humans. We're humans as well, and we're dealing with our personal situations as well. You understand? Salamata, welcome. Zulima, welcome. Yeah, so that's just it. So this person was asking who is paying for the caregiver. And they were saying not to be mean, just trying to understand because it is mind-boggling. All right. At this point, the separation has to take place. If the mother is in her right mind, she needs to get legal representation to sell the house if possible, move into assisted living, and let these grown folks fend for themselves. And I totally understand that. Somebody was saying that them waiting to die, so, you know, they can get her stuff. I hope she seek legal counsel. A lot of times, you know, as I said, these patients are not... They're not doing anything about what's going on. And plus, I don't really know whose house it is. I don't know whose house it is, so we can't really talk on that part. You know, if it's a case where it's the daughter's house and they're taking the relatives, because I've seen a lot of times that is happening as well, where they'll sell the family member, the patient's home, and get them onto Medicaid and then get the benefits and everything. So there are so many things that, you know, I don't know what the situation is, but a lot of times it's a little bit different for each case. What else they say here? Somebody says, Dalisha says, this is so sad. I've seen wounds on patients and it breaks my heart. Yeah, because a lot of times they're not turning them frequently, and these patients can't do anything. They're just lying there in that same one position for the entire time. You understand? She needs to get care on weekends, full stop. Well, you report it. That's your job. See something, report it. Definitely. All right. And we always encourage them, and we tell them that if they don't have enough, you know, if they don't have enough hours during the week in terms of the home health aid, then definitely you have to find, that is provided through the insurance. You have to find your own. So we always encourage them to go ahead and try to seek out, you know, private care for these patients, but sometimes, you know, money is limited, so they're not able to do that. So I usually ask who cares for the nurse. One of my patients had a miscarriage. My patient was crying. Yeah, nobody really, you know, nobody really cares or thinks about the nurse during those times. I started crying as well as a chaplain was our nurses need support after events like these. Yeah, and that's why, you know, you have some facilities, especially those major hospitals where you have like different traumas going on. They will have periods where after a major event, you know, if you have a child, a CPR, any child cases like abuse or anything like that, wherever they had to do like a resuscitation or a death, anything like that, they will normally do a huddle and try to just talk and hear how persons are feeling, and then from there try to give the necessary support. Because a lot of these cases, especially the ones that, you know, definitely you weren't expecting, or we know we're not expecting, but because of the age and all, you're hoping that they would have kind of turned around, but it turns out to be, you know, the prognosis just becomes so poor. Then a lot of times these facilities will go ahead and do huddles and just try to make sure we see how we could have, you know, what we could have done a little bit better to try and, you know, improve or prevent certain things from happening the next time. And just hear how persons are doing emotionally after those cases. All right. Pretty Eyes, Prit, welcome. Star Girl, welcome, welcome. My PCT, thank you so much for coming on here as well. All right. Somebody says APS not reported. That's a liability. They don't want to take care of her, but they want what she has. All right. So a lot of persons we're talking about probably, just what she has. Then somebody was says, and society still expects women to have multiple kids to care for and sacrifice for. This is so sad. Children will leave you to suffer when you're old after you have sacrificed your entire lives for them. And that is so true. And that just leads to, the fact that in the meantime, while we're, having all of these children, make sure you put plans in place to make sure you have insurance and all of those aids, whatever it is that you need whenever you get sick. So you put things in place so you don't have to be relying on your family member. Make sure you have your insurance plan out there that is going to take care of your medical bills. When you die, you have something to cover for that. Because as me say, if you leave relatives to deal with certain things, even when they get the insurance money, probably take it on it. You understand? They probably take it and spend it on themselves and don't spend it on you. And then it seems like you never really do anything during the time when you were working. You understand? Just because they are wanting to live these big life and all of them stuff there. So definitely go ahead and still put plans in place to take care of yourself later on. Sort out your 401k plan, your pension plan, have your insurance for your critical illness and all of those things. So whenever it comes to, a point where you need to be in a home, at least there is something there. And make sure you put up your little, what you call them now, it's not a will, but you want to have like your advanced directives and everything. But at the same time, how your money going to spend as well. You understand? I think probably it's a part of the will. Children are refusing to take care of their parents, and they sometimes don't want to pay the health care properly. And that's the other thing. Yeah, sometimes they don't want to pay it properly. So that's why it makes sense, nowadays, make sure you're finding a job and make sure you're contributing, do your contribution. So that way, by the time you reach a certain age group, you can be getting back certain things, when it comes on to your health. Because sometimes you realize, you hear people saying that they've been working, they probably work this amount of money, but then what they're getting back is probably like $500, $2,000, $1,000. And it's just not enough. It's just not enough during those times. So make sure we're planning, finding work or jobs that is contributing, or if you're not able to get a job that is contributing directly, go ahead and create your own 401k, not 401k or 403 or whatever, them 40 whatever. Yeah, those pension plans, go ahead and do it independently so you can always still be contributing for, years later. Make sure you have a little investment as well that will cover certain things regarding your healthcare as well. All right, another person is saying these are some situations home health aides have to deal with, along with the disrespect from the family members. Definitely, yes. And, as home health aides, we're supposed to try to, let family members know what your responsibility or your job description entails. Don't go there and make it seem like, they're paying your arm and a leg. No, they ain't paying you no money. The government or the insurance is paying you. And the little that they're paying you, it's not enough for you to go there and clean them 3-bedroom and them 4-bedroom and the patient as well. So don't let it be a case where you go there and you say yes because you want the job. If that's the case, just report the situation, whatever it is, to your home health aid agency and let them know what the relatives are asking of you. So those folks can actually go ahead and let them know what your responsibility is or your job description is. Because, sometimes you just feel as though you don't want to speak up a little bit because, this is the one job that you have. And so you just go ahead and just settle and say, okay, yes, I'm just going to do whatever the not the home health aid, but the caregivers are asking me to do, or the patient's relative are asking me to do. They say, clean the kitchen, you're going there and you wash down everything. No. Remember, you're probably just getting probably $15. I don't know. You understand? For the 4 hours. Don't go there and pick up no extra work on yourself and, go and break your back and do certain things that you don't need to do. All right. So make sure you let them know. Let your home health agency be aware of what they're asking you so they can speak with them and let them be aware of your job, your role and your responsibility as it relates to the patient. All right. That's the way they are because they know they have a caregiver. They don't care. That's true, but they don't love her. Whoa, could never neglect my parents, grandparents. They can. All right. All right, but yeah, so calling the adult protective services, getting additional resources for the weekends, those are things that, were done, and we just make sure that in the meantime, while we're waiting for adult protective services to go in and do their evaluation, or on the weekends where the caregiver is not there, I personally tell them to go and report them, personally tell them, because during that time period, they still haven't gotten anybody for the weekend. So if you kind of tell them that, sometimes they feel scared, and they will find somebody, or they will do a better job at what they're doing in terms of on the weekend, make sure that grandma or mama don't get any wound during that time period. Give me this. You understand? So definitely go ahead and let them know what your plan is, and then from there, if they feel like they want to dismiss, if they don't want you to come back and see them, okay, go and have one. If they don't want us to see you, it's neither here nor there. You do your part, you understand? So whether or not they feel as though they're going to dismiss you because you tell them you're going to report them, that's up to them, you understand? Because at the end of the day, the report is already done. And even if I'm not going to be following up on it, it is already reported. So they're still going to have a visit from Adult Protective Services or Child Protective Services or whoever. But as I said, the only time I will let them know is like if we, like for the weekend, if I definitely know that there is going to be a problem on the weekend, I just let them know. Because then, people will do things because they don't know when people are going to show up to them house. They're not going to be aware of, or they're not so sure when a stranger is going to knock on their door to say, we come here to do a little evaluation because we're hearing about, or somebody has a suspicion for neglect. So, that on weekends, yeah, man, I'm going to get up out of them bed very early and go clean up mama, turn her a million times, medicate her, feed her, change her diaper, because they don't know when they're going to get that surprise visit. You understand? So if it's in the hospital, I don't let them know. I just go ahead and just report it, because they're not going to be in my little, for a little while, and it's not like I am going to be doing any follow-up or anything. So I'll just report it, and then from there, depending on the urgency, they will decide. But like for the weekend, where I know definitely this is a situation, they don't have any caregiver, yeah, man, you just put them to work for that 2 weekend, and you just make more frequent visits. So if you normally do every 2 weeks or every month, then you can do every 2 weeks, and you coordinate with home health to make sure that on days when physical therapy or physiotherapy is going on, then you can have a home health nurse go in, so that way every day is, almost covered with a professional in their home. Sometimes it can be annoying for them, I totally understand, but under that circumstances, yeah, let them get annoyed. You understand? Because you're looking out for the patient's best interest, and that's it. That's the most important thing. Welcome, Maureen Smith. Goat 137, welcome. Jazzy Jazz here 1, welcome. Purple 876 Dove, welcome. All right, remember to go ahead and tap up the live. Do you mind? Well, I'm not gonna say. Can you just go ahead and just tap up the live to 5,000 if you don't mind, please? All right, and remember to go ahead and share it as well. All right, and remember to follow me on TikTok here, and you can also subscribe to my YT page at Think Nursing, where I share the entire video here. So just in case you show up and, you leave a little bit earlier and you wanted to hear what we discussed, then you can always go onto YT and find the full video there. All right. Then there was one person, Winbra says, I am able to move around and help myself, although partially disabled. This could potentially happen to me if my condition declines. And definitely so. You understand? Because after a while, whenever things not going well, or, people just get tired. Just like how, nurses can get burnout, or, home health aides or healthcare workers eventually get burnout. Not even them alone, because everybody get burnout in them job. You understand? Everybody get burnout in them job. It's no different for, caregivers or relatives that are taking care of us. Or taking care of their loved ones. After a while, them just can't bother. You understand? And then depending on their additional responsibility at home, then that's going to be, additional stress for them. And they just will tell you that they can't do it anymore. You understand? They will tell you, find a place and put the patient. Yeah, things like that. Because that's what they were saying to us. Like, we need to find somewhere and put the patient. They don't feel as though it's their responsibility to find somewhere and put the patient. it's the host call service, because everybody just feel as though the host call service is supposed to be doing everything. You know, they feel as though we're supposed to be doing everything for them and they're not supposed to be doing anything at all. So that's the other challenge. One of the challenges that we find ourselves facing as host call or in the host call setting. Relatives don't want to do anything, or the patients themselves either, because you have some patients who will go shopping. They will go shopping, they will do everything else, and when you tell them, go and do your appointment, they will tell you that they don't have any ride. Or you tell them, go and pick up their medication, because the pharmacy that they're working with doesn't do delivery services. They will tell you that they can't go and pick it up. We must go and do it. All right. Bibotali, welcome. TND Creative, welcome. All right. So, girl, the patient is the most important person in this situation. She needs to sell her house and go to a home where she can get 24/7 assistance. They're selfish. I would not care for them in this situation. Report them before it's too late. Definitely, definitely. And, you know, the other day I did talk about one where it was a young lady who was living with her parents, and they're a little bit older, but she's disabled. And as I say, in the situation, it was more of, you know, both parents are not on, making decisions for the patient. They don't, it's more unilateral. So the dad wants certain things to be done, and then the mother is like, no, she wants more. She doesn't want like any medications or anything like that. So I don't know what she really wants. But anyways, the patient is nonverbal. She's disabled. She's she's like in the 40s, but she is contracted. And, there's just so much things going on. She's not able to talk, and she's always just groaning. She seems as though she's in pain. And the mother doesn't want her to get pain medication. And then the dad is complaining about the 2 liter Tylenol, that the patient is getting, saying that it's going to hurt her. And I'm like, no. One is concerned about the patient getting addicted to the medication. And I'm like, this is one time that if the patient needs to get addicted to the medication, we're not encouraging it. But when you're talking about somebody that is in pain because they have decipitous ulcers or sacral ulcers that are so huge, they are not able to position properly on their back because they have wounds around that side. On the hip, it's the same thing. They have wounds there and they're in so much pain. They're not able to express to you, but you can see that, this patient looks uncomfortable. You're going to want to give them something strong for their pain. And as long as it's not causing them to stop breathing, nothing is wrong with giving them something until they feel a little bit more or they look a little bit more comfortable to you. And even though I explained that to them, it was a still strong no. They were referred to pain management and it was a still strong no. But then, we do all of that, and in that same time, the patient had a wound, came back positive, and, we started on antibiotics. So I said, okay, then after the 10 days, I'm going to go back and see the patient. Then when I go back, the parents are saying that we're not doing anything for the patient. And I said, what do you mean by we're not doing anything for the patient? Like, oh, the wound is not getting better. The patient is still in pain. They need more home health aids in the night and on the weekends. And I'm like, okay, then let's try to go through all the things that we've been doing for the patient. So the labs are good. White blood cell count is good. The wound is there, but it's not in the blood. The bacteria is not in the blood, so that is good. Vital signs are good. She has a wound care team that she's working with that comes in and do the dressing every other day. She has a nurse, a home health nurse, that comes in twice per week. She also has a home health aide that comes in 5 days a week for 5 hours each day, Monday to Friday. And we did refer to pain management. They refused. They did get referred to hospice. They refused because the mother thinks that, hospice is for persons who are dying, which we understand. But at the same time, you would get more resources and she would benefit from hospice because of different things that are going on with her. They refused. So I said, I don't really understand what you're talking about. So I said, okay, then the antibiotics that we gave, did you give the medication as the patient completed the antibiotic? No. I said, why? This is like 10 days later, 12 days later. I said, why? Oh, because the wife was reading through online and the antibiotics, she don't want the patient to get it. I said, so why are you complaining about, we're not doing anything? Why are you complaining about the wound not getting better? Like, this doesn't make any sense. You understand? If we're ordering things for the patient and we're explaining to you what is going on and you're not trying to give the patient a medication and you and your wife is not on the same page, you want medications to be given and the wife is saying no, like, who is it benefiting? This is not benefiting nobody here. You understand? The patient is not getting the treatment that she is supposed to be getting. You're not giving her the pain medication. You're not giving her Tylenol. You're not giving her the narcotic that we order. You understand? So she's just in pain. And then the antibiotic, you're not giving it to her. So I said, there's somebody that needs to step in right now that is not you nor you to go ahead and take care of this patient. You understand? Because obviously you guys are confused as to who is the patient here and who needs the treatment. So after I spent, as long as I've spent with any patient, and this is like 2 times I've been with them, where I spend like 2 hours with them. You understand? And I tell them the next time I come back, I'm not spending this long time with you guys. You understand? I'm not spending this long time with you guys to debate over what medications or, if you feel as though you're going to be given the medication. Like, you'll read on all the medications that there are side effects. There are going to be side effects to every single thing that you take out there. But we will go ahead and do our necessary testing in terms of blood work to make sure that we're not damaging certain organs with the medications that we're giving and making sure that the medication actually is doing what it's supposed to be doing. So after we explain all of that, or I explain all of that, the dad was like, okay, then he will go ahead. But he was still hesitant about, giving the medication. But, regardless of what you're doing for these patients, the relatives still complain about everything that you're doing, even when you're doing the right thing. But they're not looking at the part where after you've done all of these orders and they're refusing them, there's nothing more else you can do. You can't do anything else for them. Can't really do anything else for the patient, because if everything you're ordering, they're refusing it, like, what else can you do? But like this patient again is another one that you get flagged to Adult Protective Services because they need somebody to come and evaluate and find out what is going on. You understand? You can get social worker, you can get all of the resources that you need, but if at the end of the day, the patient's relative are not going to be medicating and doing all the things that they're supposed to be doing for the patient, you just have to let, Adult Protective Services come in and see if this is something that they need to investigate or try to get this disabled patient out of that home to go into another, another setting that is going to be better for her. Because the mother doesn't, the dad would say that the mother doesn't get up any at all to come and try to help with cleaning this patient, medicating this patient. It's only him. And these patients, these relatives are what? They're in their 80s, 70s, 80s, or 80s. You understand? And it's just them alone, but in the nighttime, he's the only one that is doing everything. So, it's sad, and it hurts me a lot of time when I have to call or make a report regarding them, but it's not about the patient's relative. You understand? It's not about the patient's relative. Them all right. They're walking, they're having their pain, and they can decide when they want to take pain medication. They can decide when they want to eat. When you have persons in situations like that where they're not able to do certain things, that's where you come in and you advocate for those patients and make sure that at the end of the day, whatever you're doing is benefiting them. Evadne Green 5, welcome. Tan 76745, welcome. Maud Hamule. Fatima, thank you for the share. Little Queen, thank you. Jacqueline Henry, Ras Gigi, Lee Roberts. How are you guys doing? Full Sexy Lips, welcome. Thank you for tuning in and thank you for sharing my videos. All right, really appreciate that. Roger Francis, thank you so much for tuning in. So definitely, that's what we have to do. All right. That means from that home health aide leaves, that lady on the weekend, no one look at the lady. Yes, because as I say, you can hear the frustration a lot of times from the home health aides because most of the time these patients, home health aides are there like 4 or 5 days out of the week. Most of them will get and spending 5 hours with them. And then on Mondays, that's when the frustration comes in because on Fridays when they leave the patient, nobody does anything for these patients. They'll come back in and the place is just like, covered in urine, stool, the patient is a hot mess, and the list just goes on and on and on. And this patient's caregiver was just like, very tearful. Like, she's just explaining, and she was just saying she doesn't understand how is it that, they say they love her, and yet still this is what is happening. So things like that, when you hear how, persons are reporting or what they are saying, you just have to take their word and act on it, even though a lot of times you might not go and see that the patient is. But definitely, if you visited a patient 2 weeks ago and, you come back the next week and you find a large wound on the butt, you're going to be thinking or suspecting something is going on. You understand? And that was just it. If she goes away for 7 days for vacation, she says she normally comes back and see like a skin breakdown. That is concerning, because it means that nobody's changing her in a timely manner or turning her frequently to prevent those skin breakdown or those wounds. And it's the same thing on the weekends. She does report that, they don't change her. She's not so sure whether or not they medicate her and how well she, is being fed. But then you have the home health nurse that goes in and do the medication boxes, and they're the ones that are able to tell that, oh, but you never take any medication Monday, Friday, Saturday, Sunday, because medication box is still full. So when you see that and you realize it's a trend, you just have to act on those things. And that's why when I go to see patients, even though the medication reconciliation for me is I don't like medication reconciliation, and a lot of nurses will tell you they hate it. When I was in the emergency room working, that was something I never really see as a thing for me to do as an emergency room nurse. Me just feel as though me have bigger fish out there for go fry. You understand? I had more important things out there, and so medication reconciliation was never my thing. If it's a case where I have my 4 patients, because that was the ratio, if I had my 4 patients and they're all admitted, and I feel like I'm ready to go ahead and do something extra, I'll go ahead and do a medication reconciliation. But it was never my thing to do a medication list in the emergency room at that time. Some facilities I go to, they do have like a medication reconciliation nurse, or not a nurse, but a tech. So somebody that goes around and do all the potential admissions. So if they feel as though this patient is going to be an admission, then they will have that person go ahead and do the medication list for that, patient. So that way when the inpatient provider comes to admit, it is up to date. But for me and a lot of other nurses, they will tell you that medication reconciliation is the last, because sometimes, honestly, you have nurses that just go ahead and look at the medication list and say, are you taking this medication, blah, 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 and they say yes, and you just say medication reconciliation done. But really and truly, sometimes the patients are not taking them. They don't even know the medications that they're taking. But sometimes we as patients, we just want to not be answering to certain questions. We just go ahead and say yes, and that's it. So it is not until I started, house call service and be doing the medication reconciliation, and I am seeing the real importance there. You understand? Not saying that it was important in the emergency room, but I'm just saying when I go and see the patients and I go and say, okay, where are your bottles? Because I'm in their home, so now we can be very inquisitive. I want to know whether or not your diabetes is being controlled with your medication. Let me see your medication bottle. Are you taking them? Or is it a case where you're just eating too much? You understand? Things like that, you can easily assess. You can see and then decide from there. So I will definitely go ahead and do my medication reconciliation. Look at their bottles to make sure that if I give a 30-day supply and it's almost the end of the 30 days, your bottle is supposed to be empty. It's not supposed to have the 30-day supplies in there. Then I'll know that, you're definitely non-compliant. And it's the same thing with these patients. You go there with their relatives, check to make sure that the medication box is actually empty, because it shows that somebody is taking responsibility for the patient. And that's just it. Prosperity Lock, welcome. Tribesman, welcome. Susie Diane Smith. Sheldon Roach, 75. Little Queen. You and Brown, welcome, welcome, welcome. And Nev, welcome as well. Guys, can you just go ahead and tap up the live, please, for me? Thank you. Don't let me just talk in vain, so. You understand? Don't let me just talk in vain, so. Give me something to motivate me to talk, all right? I know you guys want to hear. Just go ahead and just tap the screen. It's not going to hurt. and the phone not going to break. All right. All right. Let me go ahead and find some more here in the meantime. All right. And then some persons were talking about the life insurance and all of those things. All right. And then there was one person who said something. Sheena says, I should just go ahead, license the entire house and make them all clients, because obviously, you know, everybody in the house need assistance, because as I say, nobody seemed to be doing anything there. So she was saying, go ahead, license the house and make them all clients, which was just funny. And then another person was asking if this was APS, which is Adult Protective Services eligible. And I said yes. Okay. Yeah, but as I say, you'll go and you'll see that a lot of times this is what is happening in the homes of these patients. This is what. But sometimes you have the, you know, you definitely have to give, you know, the thumbs up for the ones that are there and their relatives are going above and beyond. And even though sometimes we might say that, Lord, them just, you know, just want so much. Yes, let them want too much sometimes. Even though it's, you know, sometimes in the emergency room and in the hospital setting, it's a little bit for you as a nurse. But it's better for us to have persons doing all of that, you know, and making sure that they're taking care of their loved one. Because in the home, at least you'll feel a little bit more comfortable. But then again, you have some of them who come to hospital and they demand so much. They want so much. And when you go to them house and you see the patients, they're not doing anything. So, you know, 6 or 1 and a half dozen of the other. Not all the time that they come to the hospital and be demanding and be like, oh, my mom needs to be turned, or, you know, I need this, or can you do that? It doesn't mean that when they're home, they're doing the same thing. A lot of them put on a show when they come out. And so that's why I appreciate the home visit. You understand? Because you have some persons out there and them have them little ways. And when you go to them house, you can actually see what they're doing for their relatives and for themselves. You understand? And they show them up a little bit. Some people don't like when you talk to them about it. You understand? But at least you're still able to voice your concerns about it and how we as a team, you the patient relative, you the patient, and me, and the home health nurse and everybody else that comes to your house can work towards making sure that the patient, you know, is getting the best results or the best care. Puma, welcome. Antoinette Mallet, welcome, welcome, welcome. I am Dahlia. Lawrence. Welcome, 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 Lawrence. Hey, how are you doing? Medayer Puma, I am here. Just talking about a few things here on my videos that I posted and some comments, and we're just kind of just talking, you know, general things. So, you can always go ahead. And leave your comments down below and I will answer them as best as possible. All right, I will answer them as best as possible. Yeah. Tiki58, welcome as well, Connie. Welcome, welcome, welcome. Let me get back to those. All right. But yeah, that's just it. They should have gotten someone to come in and take care of her when the caregiver leaves on the weekend. That's wicked. Okay, yeah. So why don't you report them to the authority? All right. Or on a Monday and videotape the lady condition, Jaja. Yeah, so, you know, one thing about me, and this is something that I always practice. We use cell phone a lot of times for different things. It's no different for the house call setting. I don't have a phone that they give me from my company. But, you know, I still have access to a cell phone, my cell phone. I still have access to my camera. And as long as I'm not putting the patient's face on it, then I'm good. So usually when I go, anytime I see like an insult or injury, anything that looks like, you know, is going to be a potential for, I'll go ahead and take picture. If it's a swollen limb, I take a picture. If it's a post-op wound, I take a picture. Whatever it is, your eye swollen, I take a picture. And I put it in the chart. So that way we can always have it as a reference. Any markings, I take a picture of it and I put it in the chart. It's the same thing in the hospital. Some hospitals will have their phone that you can go ahead and take pictures of those wounds. Because as I say, some patients and them relatives, they come in with some big decrepitous ulcers and then they want to sue the hospital, they want to sue the nurse because they must say, yes, My mother never come in with them kind of wound here. And when you look at it, it's 3 days a patient in the hospital, and you're wondering how is it that in 3 days you're seeing the bone in the hip. You understand? Because of a wound that is there. So I always just go the extra mile because I don't, as I say, I work too hard for my license, and I will do whatever it takes once the resources are there, and I can use it as a form of reference, or, you know, whatever it is. I am going to go ahead and take the picture and I'm going to upload it to the patient chart. So that way we can always go and say, okay, on the day of admission, you came in, this was present at the time. So nobody don't say that while the patient is in my care, you know, the patient develops some form of skin injury or, you know, breakdown. So that way nobody can say anything else. You understand? The patient would have presented before. So go ahead and make sure you utilize the iPads at the hospital, the cell phones at the hospitals that are, you know, HIPAA compliant, and you upload, and you can upload it to the patient's chart. And as I say, for me, if I don't have the company giving me a cell phone or an iPad, because all the things that I use in house call service is my personal things, I go ahead, just take a picture and just upload it to the patient chart and then delete it. As I say, I'm not saving patient's face or anything and to my phone, but in terms of the wound, just go ahead, label it, upload it to patient chart, so that way the next time I go back, I can be like, okay, well, this wound was there, it's not there anymore, or this is how it looked. And when I'm doing my referrals to wound care, at least I can have something to say, okay, then do I need an advanced provider to go in and do wound care evaluation on this patient, or can I just have the regular home health nurse, you know, getting a wound care service to come and do with that? Because depending on the stage, and then you will decide if you will need a advanced nurse practitioner who's, you know, into wound care to do that wound evaluation, or do you just use a regular nurse to go ahead and just do like a simple dressing or so. So I always go ahead and make sure that, you know, I document as best as possible, take pictures, use it for reference for anything. Videotape, no, we're not really doing a videotape like that, because where am I going to put it? I guess I can put it in a chart, but we don't have time for that one. We just take the pictures and do it. All right. And then it says that they should have gotten someone. Okay. But yeah, but majority of the comments are saying, you know, they can get additional resources and take care of the patient on the weekend, or, you know, get the patient into a residential facility where there is 24/7 in terms of healthcare assistance for the patients and the patients, things like that. Or some of these patient, the relative just need to come out of them house, come out of the room and just go and peep in on the patient every now and again. You understand? Set alarm. If you know that, you know, the patient is gonna be out of a home health aid from this time to whatever, just set alarm. And if you have 3 grown adults in the home that is considered to be daughters, like, everybody can take a turn. Is either you're going to say Friday is mine, Saturday is yours, Sunday is yours, and then Monday to Friday it goes back to the home health aid. You know, but we can put plans in place and see how we can work with it, because especially for persons who are not working on the weekends. You understand? Definitely we can always try to find ways of covering for. And if you know that, you know, during the weekdays, if it's a case where your caregiver or the home health aid is flexible, talk with them, you understand? And see if it's a case where if you're working weekends, you can alternate and say, is it possible for you to work this weekend, you know, the 5 hours on a Saturday? And just because I'm going to be home on the Tuesday for my off day, so I can take care of mommy at that time. You know, talk with them and see if that is something that they can do. I don't know how flexible they are in terms of their hours, but if you don't ask, you know, you won't know. And that will kind of help with preventing you from spending some money out of your pocket as well for those days. Because you have some persons who would definitely want to work on the weekends because they have things to do, because they have the kids to deal with during the weekday. And so, you know, you just have to just talk with them and see what they are okay with. And once you guys are okay with it, it's a win-win for you and mama and the home health aid. You understand? You save money, home health aid still get a chance to take care of whatever business they need to take care of during the week. And then mama is getting the turn and the cleaning and everything on the days when she's supposed to be getting that done. All right. So definitely that's just it. All right. Rufema Dunkley. Nurse KD, welcome. Ocean, welcome. Hadi Masri, welcome. Orenth Morgan, Niklub, Sana Olu Kelmia. All right. So definitely do that. But any questions for me though? Any questions? Any question? If you don't mind, can you just share where you're joining from or just say hi in the comment section and what time it is for you? Mine is 9:18 now. 9:18 in Texas here. All right. I did have say I was gonna do something specific. Money Boy, Palace Pitney, hi everyone, welcome. I think probably these people are doing live, I guess. It just pops up here. Yeah, so anyways, as I was saying, regarding the house call service, some of the things that, you know, like patient's relative will tend to do a lot of time when you're working as a house call nurse practitioner is sometimes, you know, if you leave your number with them, you'll realize they'll call you every second. If they have a concern, they will call. Not me. They'll try to call me, but, you know, I have a Google number that is on Do Not Disturb. So you can always go ahead and keep your Google number and just have it on Do Not Disturb. So that way, if they want to leave a message or something, that's fine. But I use it for if I am, you know, just confirming if they're home. And then I use Doximity, which is an app that is HIPAA compliant for my virtual visits, or sometimes I'll just do it for the audio visits. So if you're a nurse practitioner out there, or not only nurse practitioner, any healthcare provider where you're definitely going to be needing like a virtual platform, you can use Doximity. Let me find the app. You don't need to do anything more than just register for it because they've already gotten your NPI information. So all I needed to do was just call and verify my information because, as I say, it's a HIPAA compliant platform. I just go ahead and register. And it is so good that it has information regarding if you want to find out the management. So for example, you're seeing the patient and you want to talk about the management of diabetes, hypertension, and you want to look up certain drug information, things like that, and you need extra resource, it's there. If you want to add your telephone number for the office, so that way when you're calling the patient's telephone number, you can always just dial, and rather than them seeing your personal number, you'd have inputted in the dialer, you can add a caller ID. So you can put in your caller ID for your practice. So when you put in the caller ID for the practice, when you dial through the app, it dials and shows that you're calling from whatever your practice is, advanced house call practitioners, whatever it is, it shows there. So whenever the patient is calling back that number, it's going directly to the office. It's not coming back to your phone. So the only time you use it so you just call with it, and then the phone rings whenever they're returning the call. Because they saw the missed call, it's going to the direct office. And then the medical assistant or whoever is answering will go ahead and take the call and let me know. But as I say, it's HIPAA compliant. It's pretty nice. I like it. You can do your video calls. You can send text message. You can do your regular phone calls. You can also do fax through it as well. I didn't sign up for did everything with the fax because I don't really send out fax like that. And there is also a scribe aspect to it. And it's a platform you can meet a lot of nurse practitioners or providers, pharmacists, doctors, you can find providers here and exchange information or just ask questions and they will answer it. So I would encourage anybody, just make sure you have it because it's very good. So for example, this is just information regarding hypertension, and it literally gives you like the medications and everything, regarding that. Any new releases, any recall on anything, it is in Doximity. So it's a very trusted app that a lot of providers are using. So where is it again? So this is what it looks like. You see that D, this one? Yeah, Doximity. All right, so just go ahead and save it. Go ahead and save it, download it and save it. So as soon as you get your NPI, you can go ahead and just call them and register, and then you will have access to it. So you don't have to be spending money to get a virtual platform to go ahead and call patients and see patients, text patients. If you have a results and you want to leave it, you leave it through this platform. And if you're doing your visits, televisits, you can call them. It sends a link to their phone. They click on the link and then you and them start talking. So the patients don't have to have the actual app on their phone. When you're sending out your virtual visits and you're sending out for the link, you just send that link to the number that they provide. They click on it and then it pops up with them talking with you. All right. Teo, welcome. Simon Ambrister, selector level. Welcome, welcome, welcome. Boss lady, welcome. But yeah, so you'll find out that a lot of times, that's one thing I realize that a lot of patients relative do. As soon as they think about something, they want to talk with the nurse practitioner. So usually I just direct them to the office. If it is something that needs to be addressed, then go ahead, book an appointment and address it, because you don't give away medical advice like that for free. If it is something that needs to be addressed, if they need a test or whatever it is, then definitely go ahead, book your appointment, see the patients, bill them. If it is something that can wait for the next visit, then definitely they will do that. But I'm not in the habit of calling back every patient's relative when they call, because before you know it, you'll be calling around the clock, you understand? So I normally tell them this is what I do, and even though it's a house call service, it's no different from when you wake up in the morning and you're supposed to go and make your 9 o'clock appointments, because sometimes you'll see these patients will tell you that they want you to come and see them at 8 o'clock in the evening, 5 o'clock in the evening, 6 o'clock in the morning. No. You understand? Because they want to take their medication and go sleep for the rest of the day. No, dear. Even though we're house call and we come out to see you, I don't do after 5 o'clock. You understand? Well, matter of fact, I don't really work after 3 o'clock. You understand? I see all my patients ahead of time so I can make it back home. You understand? So I see them early because none of these patients, the conditions or whatever we're seeing them for is a dire emergency. If it's a dire emergency, then that's where 911 comes in. So always direct them to call the office, and then depending on what's going on, they will tell you, oh, they're having chest pain, shortness of breath, stroke-like symptoms. Definitely send them to the hospital depending on, what's going on. And then from there, and even if I'm sending them to the hospital, I will definitely call them, let them know this is what is happening, and still go ahead and make a documentation just to cover yourself. All right. But a lot of times you'll find that they will just be calling about everything, every single thing, and they don't want to talk with the office staff. Yeah. So I just send back information to the office staff and let them know that this is what I'm doing. And once they set the expectation, after a while, them know that them probably just send their text message to say, oh, this relative call regarding whatever, just for, documentation's sake and for covering everybody's, ASS. So definitely you'll see the message, you respond. And if it is something that definitely needs to be addressed today, then you address it. If it is something that needs to be addressed at the next visit, then it can be done so. Some patients, relative wants you to call them during their visit. So I try to, accommodate for that, because it saves me that extra text message or call from the office to say, oh, the relative wanted an update, And if they have 10 relatives at the bedside, when I go there, 1 out of the 10 relatives can go ahead and tell the other relatives. I don't feel that I need to be calling every single relative to give them information. No, that's just too much energy to be using up, for one patient. So just go ahead and, lay out your expectation, tell them what you're all about. And once you do that, you should be good. You understand? You should be good. You don't want to be the nurse that is like running and feeling so, exhausted at the end of the day because you have so much calls coming in and you're repeating the same thing over and over. You're repeating it to the home health aide. You're repeating it to the home health nurse. Then you're repeating it to the group home owner. No, no, no. Mm-mm. I repeat it. I say it only once, and I say it to whoever, and then they can send out that information to all the other persons out there. Because I think it's just unfair for us, because he'll be continue just talking like that. You understand? So find one person and then channel back everybody to that one person that you'll give the information. And especially like the ones in the group homes, if you are there and you're giving information to the home health, the owner, and they're writing it down, that's good. The relatives don't need to be calling you, asking why you change this medication or whatever, because you already tell them already, you understand? And then they call at different times. They'll call 10 o'clock in the night. So I'm going to give out my number like that, you understand? Because they don't care. They call whenever they feel like. So definitely when you go in and you see them, and especially when it's the first time you're seeing them, that encounter, you let them know. You tell them what emergencies need to get called to the ambulance and what emergency or non-emergency or what cases need to be called to the office. And you let them know that it's going to be, watch for it. You're going to let them know that depending on what is going on, they will get a call. But it's not every time they call, there is going to be a return call. You understand? Because it's just too much. It's time consuming. And not to make mention of the fact that if you have like your referrals to be done, you have to do the referrals. Sometimes I feel as though sometimes I want you to take them up, put them in your private vehicle and carry them to the appointment as well, even when they have relatives. Because a lot of the relatives will, the patients will tell her that, oh, the son and the wife have work, so they can't bring them to the appointment. And then you're like, okay, then, so where does that leave you? They can't see the cardiologist, they can't see the hematologist, they can't see the pulmonologist because they don't have a ride, because the relatives have work, So it's like it comes back down to you, and then everybody seems like they want to come and argue with you because you're not doing anything for them, because you're not transporting them to their appointment. So I literally just tell them from the get-go, like, this is what I'm doing, and this is your responsibility as a patient and as a family member. You take responsibility for certain things as well. We're not coming to your house to be doing everything. It's a team approach. And once, we do our part, you do your part, then that's it. You understand? But you're not going to be expecting me to be coming to, get your home health aide, and the home health aide is going to come and clean down your entire apartment. And then you and your relatives sit down looking at us while we're working, sweating, for the entire day. Then you want me to come and do the referral, then take it to the appointment. You don't have anybody to pick up the medication. You want me to go and pick up the medication. Like, no, like, somebody have to take responsibility as well. You understand? And that's just it. Nick at Night 320. Where you watch me forehead for? Huh? I'm forehead not that big yet, it's not that big. There's still room for a little bit more, but this is what the Lord gave me. So, yeah, not that big. But how are you, though? Thank you for tuning in. Selector Level, welcome. Kona Dum, welcome. Blaze Car, Patria, Simon Brister, welcome. And Annette Gilles. How are you guys doing? All right. So you'll find out that those are a lot of things that you have to deal with as a house call provider. But as I say, you just go and let them know what you're doing, your responsibility when you get there. And from there, sometimes they'll tell you that, they want the catheter to be changed because they don't have a home health aide, or they don't have a home health nurse, and they don't want to go to see their specialist. So they'll tell you that they want you to change the dressing. They want you to change the catheter as an advanced provider. They want me to do that, but I don't have anything to change it. You understand? If I had resources to do so, then definitely I would do it. But me not change catheter without putting on a gown. So you're not going to find me going to do a catheter with for a patient without a gown. So that's definitely something I'm not going to be doing in the house call setting. And plus, that's why you have the home health nurses going in and do all of those things. But as I said, sometimes they might not have. When I go, I might do their 1 and 2 little dressing because they don't have a nurse that comes in and they don't have a wound care nurse. I'll just do it, even though it's not a part of my scope right now, but I try to still just do it because I pull down them dressing and I realize that them can't do anything for themselves. So I just put on a new one, clean it up and put on a new one, and that's it. You understand? Until we can figure out what's gonna be happening. But the catheters can stay far. No. If they need a catheter change and they can't, get it done, then we're going to call the ambulance to carry them to the hospital to get it changed. Because the last time I had a patient, I saw this patient, the patient had a catheter in from September of 2024. I'm not exaggerating. It was September 2024, and in March, the patient still had the catheter in. I want me to tell us the catheter looked like it almost rusted. Like, yeah, that's the color of it. I was like, how long you had this catheter in? Oh, September. I'm like, which September? You understand? And it was the urine wasn't even urine anymore. It was just like milk. You understand? And then he was complaining that he was hot and everything. So he was like having sepsis. Blood pressure was so low, but the thing about it is that, sometimes you have bad experience at hospital, and that was the situation with the mom. She took him to a hospital and she never really liked the experience that he had. And as I say, a lot of times, these are like parents in their 70s, 80s, and the patients are like in their 30s, 40s. So that was it. This guy was morbidly obese. He went to a hospital. They never liked the experience, or the mom never liked the experience. So she never called the ambulance, or she never called anyone to take the patient into the hospital because she didn't want to go back to that hospital. Because a lot of times patients don't understand that when you have an emergency situation, it's not a matter of where you want to go. You have this thing called EMTALA and the laws that, govern the whole hospital, and you have the ambulance services that definitely have to abide by those laws. And so you might want to go to A, which is closest to you, but A might not be the best hospital for you. The ambulance service will be aware of the fact that A don't have this service that you need, and so they take you to somewhere a little bit further, so they don't really understand a lot of times that you have the rules that these ambulance services have to abide by. And so that was the situation. It's like she wanted to go to one specific hospital and ended up at another hospital. And he was there. And despite being there, getting the treatment, whatever was happening, she wanted him to go to the other hospital, and they wouldn't transfer the patient because the other hospital wasn't accepting. So she decided that she's not going to take the patient to any more hospital. They referred the patient to hospice, and she never wanted him to be on hospice because she thinks that he doesn't need to be on hospice. But as I say, he was really, really sick. So when I saw him, and I was like, no home health service is seeing this patient. He has a wound care nurse that he was seeing at one time. So they were providing him with certain things, but they had stopped. So they had a bunch of things at the home. But he hasn't like a dressing change or catheter change for a couple of months. Well, but as I say, the catheter was in for over 6 months, and it wasn't changed. It was like there, and it just looked like, when you have some hose and the hose outside for a couple of years, well, and it starts crack up and all, that's how it looked. It was like literally stuck in the penis. So I tell him that, look, when you just brace yourself when you go to the hospital, because this is not going to be an easy pull out. You understand? Because it was just like so white. The catheter was like so white. Like you could see that inside of it was like white. The tubing was white, and it was just like so creamy and all them stuff there. Yeah, man. And it was going to be a really bad situation for him. Those catheters, I hate changing them, because you have to be like, pushing, pulling it to kind of break up some of those, particles and all of those things there. So it's always painful for the patient, but I'm sorry, men, it happens. But yeah. So he went into the hospital. So she never wanted to take him to the hospital at first. And I literally was like, I'm sorry, but me can't do anything. I cannot do anything. His heart rate is like in the 140s. His temperature is like 104. Blood pressure is so soft, as in low. And this catheter needs changing. The urine is not even urine anymore. It's like pus. Like, I don't know what else to do. You understand? I say, you need help. You can't do this by yourself. So he needs to be on hospice, but you're refusing it. But I say, you're going to refuse it to the point where he's just going to die here. You understand? I say, I'm going to call the ambulance. She says no. I said, I'm going to call the ambulance. She says no. The patient says that he want to eat first before him going. I said, no, sir, not eat anything. When you go in, you're going to get CT scan and everything. And if it's a case where they need to do an MRI, because he had like a very large wound around the back, I said, if they need to do like any MRI or any additional testing, your CT scan, you must... You'd want your tummy to be empty. So I say, it's not going to hurt if you not eat like for the next 1 hour. You understand? The lady started complaining that the last time he was there, it's only fluids alone them give him. I say, yes, because there must be a reason. You understand? There must be a reason. There would have been so many things going on. So just don't give him anything to eat. And I'm going to call the ambulance and let him just go in and fast track everything. So he was there for like 3 weeks in the hospital. He was admitted for 3 weeks. And every night this lady sent message, not message, but it's message. Because as I say, I gave her my number because she was saying that nobody really comes out to see her. And the other thing is sometimes depending on the location that these patients are at, it's difficult to find providers to go and see them. But she says nobody comes out to see them and everything. So that was it as well. So she was just like bawling. So every night this lady, I guess because she don't have anybody to talk to, as in her son, she'll be calling and leaving messages on the phone from the hospital, just bawling. And I don't know what else to do. You understand? Until at one point she was like, the office is not answering her calls and all of those things. But the patient is not in the service anymore. You understand? Because the patient is on hospice now. But I don't know what was happening. Nobody was answering her call. But it was just like sad. I called her just to find out how he was doing. And she was upset that he was going on hospice officially. And, that was just it. But she had agreed for that. And yeah. But it's just challenging sometimes when you go out there. Jade Don is asking, were you ever a little timid to do certain aspects of your job? Not really. So I guess because I'm more, so first, let me tell you. So I was trained in Jamaica, and I think that was my best, the best part of my nursing career or my training as a nurse. I think I was trained well in Jamaica. I know I was trained well, not think. I know I was trained well in Jamaica. And so that I'll say that's a plus. And then the other thing is, in Jamaica, a lot of times we are short staffed. We don't have the resources. So we tend to find ourselves doing or going above and beyond, thinking outside of the box in terms of taking care of these patients. And so because of that, I'm very open to certain things. And then we tend to have a lot of traumas in Jamaica. So you're always, waiting for certain things. So when I got here and in the emergency room, the same thing, some of the cases are the same. Some are a little bit different. The ones that I wasn't really that 100% accustomed to was like the ton of bed bugs and the scabies and all them stuff there. Yeah. But in terms of like, your regular wound, we tend to have a lot of wounds. And depending on the hospital that you're in Jamaica, sometimes you'll find some necrotic wounds and all. Wounds that has worms. So after a while, they kind of... because as a student nurse, you're going out there and hear that somebody has a breast that has a wound or a head wound that has worm. You're curious. So you want to go and try to count out the different worms. You understand that, you see? So after a while, I wasn't really scared. It was just something, even though, yes, it's a patient, but you were curious and you were excited. So I think that kind of helped with, building me and making me confident. And when we go out there, I just go out and, just do my thing. The timid part was when I started house call service and going in because, I know that a lot of persons do have dogs, but I never really understand that even though they have a lot of dogs, some people don't really take care of them house that well. And the first time I go in a person's house, I was like, okay then. Even though that house wasn't that bad, but it was just the smell that was like a big turn off because most of the time, the patients are coming to you. So you're not really getting the full, the 100% of what is going on in the house. And for me, when they come to the hospital, I always change them out of their gown, because I just feel as though whatever they have at home, they're introducing it in the room. And then me, if you go and do certain things, like I always want to feel comfortable knowing that I'm not going to be leaning on a patient in the bed to do a EKG, do a catheter or whatever, and then transferring, something on my clothing and then bring it home and all that. So I'm always like, trying to be protecting myself. So it was more of when I start house call service and seeing all of these things, and when I go in, I see cats running all over. Because I tell you, some hosts, them have a whole heap of dog and cat, Yeah, man, them have a ton of dog and cats. So, I know 1 or 2 times me stay outside and be talking to the patients inside and turn it into a virtual visit. And that was it. You understand? After that encounter, me not go back there because, after a while, there are certain things I can't tolerate and some I can't tolerate. I definitely cannot tolerate the dogs and the cats. But if you have one dog and the place is clean, because you have some persons who don't let their dogs go in their beds or on the sofa, and the cats on the same thing. You understand? But you have some place, when you go here, they're all over the place. You understand? Here, all over the place. You probably look, I used to hear flying because the dogs and whatever that's in their little kennel just shaking. You understand? Me not go back at them places there. But if their cats and their dogs are well, in a little area they're contained properly, then fine. I don't have a problem taking care of them. And then you have some of them, the dogs, them bigger than me. You understand? And them so loud, them not stop bark. It is a turn off. Me ain't going back there. I'm just going to stay outside, ask you a few questions. If you need medication refill or if, whatever it is, take a picture, send it to me, send it to the office phone, and we go ahead and treat it. And then whichever nurse or provider is strong enough to go out and do that part. Because you have some persons who are dog lovers, cat lovers. Yeah, they will go out and do that one. But, that was just it. You have, sometimes they'll go out and the entire place is just covered with incontinent pads. You understand? Those little pads that you put on the bed underneath the bum of the patient so that it doesn't soil the patient bed. So the patient don't soil the bed whenever they pee. Sometimes you go and you see it cover the entire floor in the patient's house. Some just stay right at the door. Because on it you see, probably the dog have diarrhea or something, stuff like that. Me not go back there. You understand? I have one encounter. That's why I say, I don't have a problem doing the first encounter. Because when I go, I document, and then depending who wants to go and see that patients after for follow-up, then that's up to them. You understand? But that was just it. But otherwise, I'm okay. I'm okay. Sometimes I'll go and, you might see the home is not in a good condition, or you have some tons of trees over the house and it just look dark and scary. Yeah, leave my bag outside so that way me can run. I leave my bag, so when I go I will, I see how the place is. If I see how the place is and there's not much lighting, then I will, just stand outside, call whoever, and then from there. But we're not going to really go inside like that. If the place is open and well developed, then I don't have a problem going in. And then from there. But if there is not poor visibility, because as I say, some places or some homes you might go, the house is there and the people them not chop down the place, so the grass or some things are growing on the windows and the doors and whatever. Me not going there. Me not going to them places there. So apart from that, it's okay. But the dogs and the cats and the darkness, yeah, totally not my cup of tea. Yeah. Some of them will fire me from before, they will tell you that they don't want you to come back. I'm say that's fine. You understand? They have to understand that I'm looking out for myself as well. So in as much as probably, yes, we're healthcare providers and we have a responsibility, I don't think if the environment is unsafe, then we have to do the job. No. No. You don't have to do it. You can refuse. And if I go there and I feel as though, I can't cross it because there's just too much puddle of water or there's just too much dogs. And sometimes you hear them tell you that, the dogs are friendly. Dogs are friendly. I said, no, ma'am. The dogs are friendly. These are friendly dogs. And they're just running around. I said, no, I'm going to wait until you put them away. And then from there, if they can't put away them, then we just stay outside, as I say, and do the evaluation, and that's it. and then they're off my list. I won't be going back to see them. Hi TS, how are you doing? Thank you so much for tuning in. Stephanie Audrey, thank you. Are you planning on going into house call Jadon, or are you a nurse? TV, welcome. Nico, welcome. Yeah, but apart from that, no. I did talk about the one with the, I don't know if you saw this, the one where I talk about the patient who had the pew-pew in the hand, that morbidly obese patient with the pew-pew. That one, as I say, with that one, it was in the latter part of the evaluation, the pew-pew was shown or seen, and I'm just stick with myself at that time. I was like, yeah. You have to be very smart how you do these things, because you don't want it to be a case where people see that you are there doing an evaluation and you see the pew-pew and they say, oh, you're scared of it. And they probably start doing certain things. You understand? So what I do is I just be like, okay, then, I will go ahead and just do this part, or, I'll go ahead and order these things and just start walk back way. Yeah, man, take a little time and just scroll out of them house. Yeah, man, and just say, enjoy your day, and you cut. And you just document and you hand off. So whoever wants to go ahead after me document and and I tend to I tend to flag the notes as well, put a little comment, so that way every time somebody opens a chart, they're able to see that the patient has a weapon, or the patient has dogs, or multiple cats, or, if the floor is covered in stool, then you can know what to expect when you go there. Yeah, because I went to one and as me say, it was like a pasting on the floor. That house not clean for decades. But, the relatives call saying that they want a wellness check. Yeah, some of the relatives out there, them not easy, Them not easy one bit. They don't care about their relatives for real. They don't care. They will call and tell you that they want somebody to go in and check on mama. Yeah, man, because mama don't have a phone, They want somebody to go and check in on mama. And that's their mom. And when you go there, you have to wonder what happened here. So let me tell you, I went to this house, and as usual, I don't go in them. I'm not going in the house. I opened the door, and when me tell you I opened the door, it was like a scent just licked me in my face. There was a scent that literally just leave me standing at the door, and I was wearing my mask. I saw this lady in the parking lot, and I was wondering where was that person going, because I thought I was the only one that was kind of putting on so much things. And this lady was putting on a hair covering, she had on a mask, she had on a, just like when you see patients, persons going in for COVID-19, that was it. And I was wondering where she was going. So anyways, I sit down in my car, waiting until I see her coming back out of the building, and I said to her, hi, I'm Nurse Practitioner X, and I was just wondering where you were going, because you seem as though you're covered in whatever. But she had her vehicle that was marked with the company, the house call service, not the house call, the home health service for the patient. So she says that she went in to see one patient, whatever. So I say, why do I feel as though this patient is whatever? So she's asking me what company I'm with. So I told her. So she said, oh yeah, I'm working with your company. So it was at that time we're having a conversation. She's like, you're not dressed for that room. I said, what you mean by that? She said, yeah, you're gonna need a full overall, you're gonna need shoe covering, you're gonna need your face shield, your hair is gonna need to cover, and you're going into that room because there is total, the entire flooring is covered with layers of stool from the cat. Like the cats the cats are in the house roaming, multiple cats, and it seems as though nobody has been there for decades. So anyways, I went ahead and called the daughter and was asking, and she says that nobody don't provide her with no home health aid to come and clean up the place. I say, I beg your pardon? I say, I beg your pardon? What do you mean by nobody, provided her with home health service? I said, that's not what home health services are for. You understand? You guys are taking this thing to a different level. This is not what home health service is for. We come in and we take care of the patient, but you can't expect that whenever you don't have a home health aid, you are not going to be going over to clean up. You understand? And I was just so upset about it. I say, you guys need to figure out how, because she doesn't have Medicaid. So that means she's not going to get a home health aid. You understand? She don't have it. So is it a case she's just going to be lying there having cats, just passing stool on the floor and everybody just come and just walk on it and spread it out, and give it a different layer? Like, no, that don't make no sense. You guys need to figure out what you're doing about it. And then the other thing about it is, sometimes these apartment complex, that's something I tell you, saying, when you're planning on renting a place, especially if you're an international nurse, make sure the people them change out the carpets. A lot of times they will go ahead and change out if it is really, really soiled. But may I tell you, that's why I say I personally will take the time and go and look at the apartment. You understand? So make sure you're taking the time. You're not signing any long lease, because some of these places, them don't change the carpets and all, and there's a lot of things that go on those carpets. You understand? Make them change out the carpet, and the place is just smelling good, because I don't understand how she was even still in that apartment. How she would have been still in that apartment if the company or whoever is, operating that apartment complex is not doing checks. You understand? If they're not doing checks, because I would assume that is something that you would put in as a part of your, your plan to make sure that your apartment still maintain its value. You understand? Make sure you do regular checks, you do your pest control, do those little sprays and all them stuff there, repainting, so you can still, if you want to charge $1,000, $2,000 for your room, then, it makes sense because your place is always clean. But I don't know how that place was just so dirty, and covered in so much stool from that cat. But yeah, it's just a lot. What was it? Who is this? Jaden is asking, what was it like studying? Is the workload so much that it will make you explode? Yes, the workload is a lot, because remember, you're not a nurse. You are, you are just a regular person out there going to start your nursing journey. So when I guess if you're, very smart, you don't have to probably study. You have some people who don't study and, they score really good on their exams. So it depends. But it's going to be a lot of work when you're doing your nursing program. You just have to find balance. Just make sure that you're balancing your time. You have your NRSG courses, which are your nursing courses that you definitely don't want to be failing any of. So you're going to have to focus on those. When it comes on to pharmacology, health assessment, pathophysiology, you want to focus on those, because those are the backbone of your nursing, study or your career. But it's going to be a lot of work. But when you're there and you see everybody else studying, you're going to want to make sure you do that. You're not going to want to fail anything. So you're going to put in all of those time and the effort into making sure that you pass. But it's not going to be a case where, you're going mad out or you're going to go to a psych facility. No, unless you are that kind of person that is going to cause that to happen. But once you, set up get a timetable, not a timetable, a study routine or, regime going for you, then you should be fine. So make sure you have plans in place to, make sure you're doing your assignments on time and your clinicals when it's time to do that, so you don't have to find yourself exploding because you have so much, assignments to turn in because you're late on them always, so they're backed up and all. So yeah, that's just it. But it's a lot of work, all right? It's a lot of work. Well, let's say here in the US, I don't know if it's a lot of work here in the US, because sometimes I see some students studying, and what I was doing in Jamaica for my nursing program, I don't really see anybody do them stuff there up here. So it depends on where you're trained, or you're going to be training. Then I guess it's going to be a little bit different. But I feel as though my training was, it was difficult. It was hard, because when they're preparing you, nobody's not spoon feeding you. We were more, it's more, let's say, old school. Yeah, because now you have phone and everybody can walk with phone. And even though, yes, you're an adult in Jamaica and you're doing your nursing program, a lot of times, we weren't allowed to be on our phones on clinical sites, things like that. So chat wasn't our closest friend. And plus, we never have chat at that time. But Google wasn't our closest friend, or cell phone wasn't our closest friend, because you weren't allowed to be like on a clinical site using your phone. You have to have literal textbooks. You have to have a medication, a drug guide to look for your medication. So those were always like mandatory things that you have to have with you at clinical sites. So it was more hands-on than anything else. It wasn't like a lot of electronics that you're doing. And even though, students are still expected to have all of those things, your tape measure, your pen light, your medication drug guide, your nursing dictionary, all of those things are part of. So yeah, they treat you like, so why you make it sound so hard? Because it's hard, but it's not that hard, all right? So don't let me, prevent you from going out there. No, I'm just being realistic with you. When you go out there, it's going to be a lot of work. But you just have to put things in place to make sure that you don't feel it that much throughout the program. Yeah, you don't want to come out and just say you have a degree and then you can't even go in a room and take care of a patient in your first year. No, that's the part that I don't like. And that's why I say, like, it depends on where you're trained, because I've noticed a lot of students, they will graduate and they're nurses now. Them can't start an IV 2 years and they don't know how to do an NG tube placement. Like, things like that. When I was getting my training, by the time we were finished, we were operating, we were, doing management. We know how to manage an entire floor. We know how to do catheterization. We know how to do NG tube placement, your IV, blood draw. So you were very, very, I'm going to say proficient at, or competent at certain skills. You understand? No, I realize that a lot of people don't even know if you put in a catheter. You send them to get a catheter kit, they don't even know what it look like. And at that time when I was, getting my training, it's not like we had tons of catheter, those fancy catheter kits using, or those chest tube drainage system working with. No, we were using bottles, and tubes. No, you have those single-use thing that you just open, throw away when you finish with it. But that's what I'm saying. Like, it depends on where you were trained and other things, the resources that you have at hand. But a lot of persons had them and they start working as a nurse, and it scares me. You understand? Because they really don't know anything. They really don't know anything. I know that they're on internship, but even so, on internship, you're supposed to know some stuff already. You're supposed to know a lot already on internship, but a lot of persons don't seem to know much, which I just feel as though if you spend 4 years in school and you do clinicals, at least there's certain things that you're expected to know how to do. First year in nursing, well, you do 4 years of nursing school. First year is usually like observation and general courses. Then your real year starts on your second year when you start your NRSG courses. And for me, during that time, the summer before you start your real courses as a student nurse, where it's the NRSG, we already know how to do blood draw. You understand? You already done the phlebotomy course. Now I find that students or nurses coming out of school here in the States, they are graduated and they don't know how to do blood draw. Like, that not really sit well with me, because then you have them on the floor and sometimes they're in the emergency room. Some of them want to go to ICU, you understand, and they don't know how to do an IV. You understand? How does that even work? So that scares me. But as I say, first year, I already know how to do that. Then in the same first year, which is the second year of nursing, your 4-year nursing program, you already know how to do your catheters, you know how to do your dressings, you know how to do, what else? Dressings, catheters, NG tube, you know how to do suctioning. So by the time you reach in second year, the third year, you already feel comfortable with certain skills, and you're building, you're taking care of your patient and you're managing them as you go along. So by the time you finish and you're in fourth year, which would have been your third year set of courses, to complete your 4-year program, you realize you know how to manage patients. You understand? The only thing is that we never really had certain resources at hand, but you already trained using the international standards. So we know what we're doing. You understand? It's just that we don't have all the resources at hand, but you get the actual hands-on training with 1 or 2 of the different resources, the kits, at the time. And then depending on if you go to one of those private hospitals in Jamaica, then you will experience working with some of those things. But yeah, we had a lot of experience. So when you graduate, you don't really feel that timid or you're scared, to do certain things. You just go out there and you start functioning as a nurse. You understand? So that was just it. And that's why I say, when I got here, when you ask the question about if I felt timid, no, because my entire preparation, it's like you were prepped, or you're being prepared during that time to go out there and be functioning. We don't have like computers out there that we are sitting down and doing typing, clicking. Chest sound clear, abdomen or the bowel sounds present. We don't click like that. You have to literally write out your SOAP notes. So if you have 7 patients seen for the day, you have your little book that you write in your SOAP note, and you're writing your interventions, you're writing your diagnosis. So even though you're probably not writing everything in the patient's chart, it was an expectation, because you have your preceptors coming around to check your book to make sure that the diagnoses are correct and your assessment is reflecting what the patient situation is, and you have to come up with your plan of care and all of those things. So you're still having in your mind, like your differential diagnosis, your risk diagnosis, all of those actual diagnoses that, is presented based on your current situation with the patient. So when you leave, I feel as though we were a little bit more of a critical thinker. We had a lot of hands-on experience and we were prepared to go out there. So I'm never really scared about anything that comes on, when I started here. I think I see assignments take the form of essays, or they are more practical. The question is, where are you now, Jadon? Because it depends on where you're going for school. It depends on where you're going for school. You're in Jamaica. Oh, so what school you plan on going, Jadon? And make sure you follow me on YT. Go and subscribe to my page over there. All right, to talk about my journey and everything. UWI. Oh, so you're going to go to UWI. So basically, the exams, I don't really know much about UWI. I'm going to talk about Northern Caribbean University. That's the Adventist University. That's the one I went to in Mandeville. So I want to talk about my experience there. We had a mixture of different, types. So you have your true and false, you have your question, your multiple choice, you have short answer, you have essay type, and you have clinicals. A lot of times when you are doing your classroom, so you have your regular classroom and you're also doing your clinicals at the same time, you will find that the preceptors will come and they will ask you questions on spot. They will also ask you to go ahead and do your practical exam. You'll do your practice exams as well. So that is something you're going to have to get comfortable with, presenting your patient to your preceptors. I know that UWI was pretty okay, but I don't know if they were all that, Yeah, I think a lot of times, UWI was pretty easy. UWI was pretty easy with certain things. I know with my school, they were very, very, strict and wanting to go above and beyond. And them way there? Yeah, man. So that was just it. Little Queen or Queen, NCU is your alma mater. Yeah, man. Welcome. Do I know you, Little Queen? Were we in the same batch or not? Yeah, but I did enjoy my training down there because we get a mixture of everything. If you're talking about the final, when you've completed your years and you're supposed to go do the RN, that licensure exam, the RENR, if you're talking about that, it's going to be a case where it's the same format. Well, let me take that back because I hear they changed the format. But I know you had the clinical, the practical exam that you have to do where they place you at one of those major hospitals and then you graduated in 2018. Okay, yeah, that's after me. Okay, So you have the, the practical exam that you have to do at one of those major hospitals, or even one of the private hospitals, because I did mine at one of the private hospital. And then they do the same care plans and everything and try to find out how the diagnosis link with each other. So if the patient has like hypertension, the patient has a stroke, diabetes, try to find out, how they link, how they relate to each other. So things like that, they kind of just pull your brain on the spot to find out how you're thinking. Is it the hypertension that leads to the stroke? Is it the stroke that leads to this? And just try to find out stuff like that. And your diagnosis, your plan of care itself, you'll have to do that. And all the time you have to find a risk diagnosis as well as the actual diagnosis. So all of those things that they teach you, yeah, you have to do it. You have to do it. You have to do your procedures. Everybody had to do a medication administration. All right. And you have to do one, I think we had to do 2 procedures, 1 or 2. Oh, 2 procedures with medication administration included. But I ended up doing 2 procedures like NG tube and NG tube placement and catheterization for my patients at the time with my medication. Yeah, so that's just it. But after a while, as you go along and you see how they're doing their exams and you're learning, it's gonna be better at the end. And a lot of times, you will realize that the how they go about with the questions and answer, the comprehension or the essay type questions, it's the same thing. It's always going to be mostly about pathophysiology. So once you know your pathophysiology, you should be good. So start focus on your pathophysiology because that is the backbone, I feel. Because if you know your pathophysiology, then you can take care of any patient and you can be, whatever in terms of signs and symptoms you'll be expecting, or it will kind of help you with that. So USR. So are you here right now, Little Queen? USRN. Well, yes. What kind of question is that? I see your big flag there. I'll look to see. Well, I can't look at your page there, but yeah. Good as Wendy. How are you doing? Welcome, welcome, welcome. All right. One Junior King. Welcome. But yeah, so, it's not going to be that bad. It's not going to be that bad. Just, stay focused and you should be okay. Let me see here. So why Yui though? Not saying nothing is wrong with the others. I'm just wondering why Yui. Jadon, are you from Manchester? Because a lot of times, the Manchester people them want to go to Yui. So I just have a feeling they come from Manchester and want to go somewhere that is different from home. Is that the case for you? So Little Quen says, yes, I am in the US 2 years now. Okay, nice, nice. Did you have a good transition? I'm from St. Catherine. Okay, you're from St. Catherine. Okay. Yeah, so that was just it. But yeah, I don't have any regrets with, where I did my nursing program. Not saying that I may have any other option, like, I could have gone overseas or whatever. But in terms of doing it in Jamaica, I have no regrets with that. And if there is anybody here that, is planning on becoming a nurse and you're in the States here and you're looking for a really good nursing program, I would say enroll in any one of the programs in Jamaica. Yes, the programs them down there are good. All right, when you get out, you're not going to feel timid and you're not going to feel as though you're going to work hard, You're going to work hard. Not to the point where they make you cry or anything like that. No. But it's going to be a lot of work you're going to have to put in to get your degree. And when it's time for you to do your exam, yes. All right. So I would say if you really want to get a lot of hands-on experience, definitely Jamaica is going to be the place to get that done. But in terms of the resources, it's here. But I think your critical thinking skills and, how you go about with managing your patient, prioritizing, time management, all of those, you will be very, very strong by the time you finish your program. So Little Queen says, I think it's Quinn. Yeah, good transition. Trying to see if I can do FNP next year. How long did you work here before? Oh, just what? Well, I started probably like a little bit a year in, because I was working in Jamaica as a nurse for 4 years, and then I transitioned here. So, yeah, probably 5 years in, 5+ years in, I started. And then by the time I finished, it was probably like 8 years. 8 years in, something like that. 8 years, 9 years. Because COVID came and kind of messed up the whole thing. So it kind of extended it a bit. But once you have the 2 years, I see a lot of persons enrolling. Not saying that, 2 years is good enough if you only have 2 years worth of nursing experience. Not in the States here, but overall. I don't feel as though, I don't think you are ready. Let me not even say that because don't want nobody cuss me. But I just feel as though you need more experience. 2 years is when you just get in, your foot wet, your hand wet as a nurse, and getting comfortable with certain things, understanding, and not really understanding the pathophysiology, but putting something in terms of the presentation of the patient with the pathophysiology itself. I think during that time you get a little bit more, grounded into nursing, let's just say, with those 2 years. And then if you have it 2 years, then yes, you can go and do it. But I just feel as though you need a little bit more experience because you're going out there in the capacity of an advanced provider. And I just think, critically, you might need a little bit more experience with dealing with, because it's not only about, a lot of persons might let it seem as though it's pretty easy, but I don't think it's that easy. I might talk about it sometimes as though it sounds easy, but it's not that easy. It's a lot of work, and depending on where you're working, yes, you have your autonomy and all, but you have to remember that at the end of the day, you have to be mindful as to why you're making certain decisions. All right, and if you don't have a lot of experience to say, okay, then this is why I'm doing something, then that can be a problem. And that's just how I feel. All right. Hi, Carlene Scott. Welcome. How are you? Maureen, Minister Sharon Hall. How are you doing? Yeah. Any other question? Yeah, I think you need experience for real. I have 6 years. Yeah, definitely. 6 years is pretty good. And that's the one thing I really appreciate about, Jamaica. Because in Jamaica, even if you want to do your master's, whether or not you pay for it, privately, or you're doing it out of pocket, not private, what am I saying? Even if they're not sponsoring you through the government system, you still have to have, I think, about 5 years of nursing experience before you can actually, go and do your master's, something like that. Like if you want to do, because at the time when I wanted to do public health, I needed to do I have to do the certification. So it's the certifications I had to do. I had to do the certifications for midwifery and the psych, and then you can also go ahead now and do your master's for public health. I don't know if things have changed, but you had to have probably like 5 years. By the time I finished, it would have been about 5 years of experience before you can actually get into one of the master's program. So I do appreciate that, because it gives you time to prepare yourself mentally and critically in terms of, your thinking skills. Not so much eventually your skills, your hands-on is going to be good. But overall, I think it prepares you well to go out and, function in the capacity of a nurse practitioner. Because sometimes what I realize as nurse practitioner, like sometimes I see some of us as providers, I don't know if it's because we know that we have the resources at hand. We just order. We're not even thinking about what we're ordering. You understand? And whether or not it makes sense. And I'm not saying that I'm the best nurse practitioner. I'm not the best nurse practitioner because I'm still learning. But some things are like common sense. You understand? Some things I feel are just common sense. And that's why a lot of times probably some providers are looking at us to say we don't really have no sense. Yeah, man, I'm gonna say it. Sometimes I say that we don't really have that much sense because we're not critically thinking about certain things, because as soon as we see a lab value that is abnormal, we just go ahead and just order something. And you're not really looking at everything. We're not looking at the patient, the signs and symptoms of the patient, you know, and whether or not it's really necessary. So things like that, you know, it makes the profession, or it makes us all look like we're not really thinking, or we don't really know what we're doing. You understand? Because the only thing we're doing is referring. Oh, let's refer to the nephrologist. Like, for example, like I was talking with a young lady, and apparently someone said to her that she was ordering too much tests on the patient. So she came to me, like, you know, not really my friend, because we don't really have friends like that, true friends like that in nursing, apart from the ones from back home, you understand, in Jamaica, that I was trained with and working with. So, like, I have associates here, you know, my co-workers. So, it's more like she was explaining to me that the nurse was saying that she was ordering too much, or the nurse practitioner says that she was ordering too much. So I think she came to me thinking that I was going to be on her side. And it's not a side thing, you understand? It's just how I feel about certain things. Because at the end of the day, you want to make sure whatever you're doing for the patient is not costing them an arm and a leg. Because when they need the $2 little $10 to go ahead and pay for the medication, they don't want it to be said that you refer them to a cardiologist, and the cardiologist is going to say, come back in 1 year because whatever you refer them for never really needed a referral, you know? And so they spend their extra $50 to go and pay for a cardiologist visit, when really and truly certain things that the patient was experiencing or not experiencing, or the EKG showing, is something that doesn't need like an immediate follow-up right now. And they spend the $50 and no, they don't have the $10 to go and pay for their 90-day supply of medication. And so it put this patient in a worse off situation. So she came and she was saying that they were saying that she was ordering too much. So she went ahead and was ordering for every abnormal kidney function test, or if the patient has chronic kidney disease stage 3, she would go ahead and refer the patient to a nephrologist. She would go ahead and order an ultrasound of the kidney and some other things. She would put the patient on blood pressure medications and all, which the blood pressure medications I would do, but I'm not going to order an ultrasound for everybody that comes in and say, like when you look at the renal panel, it's saying that the patient has chronic kidney disease stage 3A, 3B. So I was saying to her, it depends on what's going on, because I look at lab values and I assess my patient, and I also go ahead and find out if the patient is having certain symptoms before I decide on what I'm going to be doing. So she's saying that she was trained to go ahead and order if there is, you know, an abnormal renal function. She's trained to go ahead and refer if the, you know, the testing is abnormal. So I'm like, well, that's how she is trained. And yes, I was trained the same way, not necessarily like that, because at the end of the day, it's always going to be based on the patient's, your evaluation of the patient, because 3/4 of the information that you get in terms of what is going to help with your diagnosis is going to come from your assessment of your patient. So whatever the patient says, whatever you see, whatever you feel, you know, and then the little additional testing that we might do, yes, you're going to use that with, you know, making your diagnosis and your plan for your patient. So I was saying to her that I don't really go ahead and just order like that, especially when you're dealing with the geriatric population. A lot of these patients, just like how you have a new car, and when you get the new car, it smells good, the wheel them look good. It's the same concept with the human body and the organs. After a while, it starts wear and tear and mash down until you're dead. You understand? The same thing with the car. You will drive it a couple miles and it wear out and it done. So when a patient who is 80 odd years old having stage 3A chronic kidney disease, it's not that much of a concern for me, as long as the patient is not having certain symptoms. If the patient has a chronic kidney disease of 3A, the classifications, 3A, yes, 3A is probably running 70-80 in terms of your percentage for your kidney function, or how your body, your kidney is functioning. I'm not going to be like, say, you know, 100% concerned about that because that is like a 70-odd-year-old, 80-odd-year-old person. You're not expecting their kidneys to be functioning at 100%. So I'm not going to be jumping to say, oh, let me order, an ultrasound on that patient because more than likely, what are the chances of that patient's, ultrasound coming back normal or abnormal to the point where they need to see a nephrologist? So she go ahead and order all of those testing. If the patient is 90 years old, she refer for nephrologist, she refer for ultrasound, or she order ultrasound and she put the patient on the blood pressure medication, which, as I say, nothing is wrong with protecting the kidney. But I'm not going to be ordering an ultrasound, especially if the patient is not having any problems. You understand? And it's just a chronic kidney disease problem going on there for a 90 or 80-odd-year-old. So she's like, well, that's how I do it and that's how I was trained. I'm like, yeah, I understand. But at the end of the day, you have to remember that these are patients that are spending money to get those testing done. So you don't want to be testing unnecessarily, referring unnecessarily, because then you send that person over to a nephrologist and nephrologist is saying, why did they even send a 90-odd-year-old over here, with a chronic stage like 3 kidney disease? Like, they're not gonna do anything about it. So how I do it is I will go ahead and if I see that, I will go ahead and repeat the renal panel in a couple of weeks. Probably like a month time, see if it is changing. If the results are, going down, then definitely you have reason to go ahead and, refer the patient. But if it's baseline, hanging out there, the patient not having any symptoms, you can always just watch and wait and then from there. But I'm not going to be ordering certain testing just because of a lab results. And that's it. So, just go out there and make sure you're thinking. That's why I say critical thinking is very important. Critical thinking is very important. If you understand pathophysiology, well, and you can say, okay, then a patient is having chronic kidney disease and you're looking at the lab values, but the potassium is good, the chloride is good, sodium is good, all of those things is good. And the only thing that is abnormal is like, the kidney function there, then you can be like, okay, then this patient is not symptomatic because of whatever is going on with the kidney, or, it's not bad to the point where those are deranged. So you can always repeat the sample to see if it is trending up or if it is trending down. And then from there, you can go ahead and do your referral. But when you're going to just refer because of the one result and you don't have anything to compare it with at best baseline, then you send them over to specialists and then the specialists look at us like, okay, then what's going on here? So I think you need, a little bit of an experience before you jump in, because at least you have something to say, okay, then if this is going on, I can do this before I rush to, referring this patient over there or doing this $1 million workup that eventually going to come back negative. Hi, Nurse EMs. How are you doing? Do you want to join me here? Let me invite you and see if you'll accept it, because I know you had a lot of questions. Omo, welcome, welcome. How are you doing and how is school going? All right, so definitely. Lillian Casey, welcome. Jen, are you here? Let me see if you're here. I'll send you a link. Okay, nice. All right. Howard, thank you so much for the follow. All right. Who's this? Crema Sante. How are you doing? Oh, Nurse Yems is here. How are you, Nurse Yems?
I'm good, thank you. How are you?
I'm doing fine.
Yeah.
How's the weekend going?
Good. I'm on shift, night shift.
Okay.
Yeah.
Patient sleeping?
Yeah, all sleeping, all
Oh,
settled.
come go trouble you a while ago, come here and say no live streaming on the live
Exactly, yeah.
on work.
Exactly. I had to tell my colleague, oh, I'm just on live. Everyone's sleeping, but we're all good.
Okay.
Yeah.
Okay. So
Mm.
What floor you work on? Do you work on like a Jada? We had off boat. You work on a like what floor you work on?
Psych ward.
Hmm?
Psych ward. Psych.
Oh, psych. Oh, that was never my. I don't have a problem working on the psych floor, but it was never my
Mm,
favorite. So
mm,
you are in the UK right now, right?
yes. Yes.
Okay. Did you have to do like a psych course to work on that floor, or just a regular?
Yeah, I trained in the UK.
Mm-hmm.
So I trained, so in the UK we do general, we do mental health, we do uh, maternity. So I specialized in mental health.
Okay, okay, nice. So I guess you'll be doing that in psych in as a
Yes.
advance.
As an advance, yes, I will be eventually doing my nurse practitioner
Okay, that's
course.
nice.
Yeah,
That's where the money is.
exactly.
Mhm. And not because the money is there, I don't want persons to think of it, and this is just my take on it. Not because the money is in an area, it doesn't mean that you're always fit for that, department or that field.
Mm,
You understand? Make sure you have a love for it. And if you know definitely you want to go into psych, you want to go into peds, definitely start
mm,
off with getting your foundation in those areas. So like her,
mm,
she wants to do psych and she is currently working in that department, So if you know definitely that's where you want to go, as an advanced provider, then it's always nice to try to get experience in that area. So by the time you
yeah,
get there, you know what you're doing.
yeah. I'm 5 years in psych now.
So you'll
Yeah.
you'll do well. You'll do well with that because I know a lot of persons are saying, "Oh, I want to go into psych," and then like I met this nurse practitioner, but she was doing I think she was doing FNP, and then she switched over
Mm,
saying that, "Oh, there's so much money in psych. There's so much money in psych." I'm like, "Yeah, there's so much money in psych, but are you ready for psych?"
mm,
And she was like, "Yeah." So she switched over, and then every single time she come to work, she's stressed out, she crying, she can't deal with the
mm.
patients, and I'm like, "You haven't even completed the program as yet. So how are you gonna be doing when you have graduated and you're a full psych nurse practitioner? What are you gonna be doing at that time?" So then I heard her saying that she's switching back to FNP. I'm like, no, like if you
Mm,
guys, are prepping for, if you know what area you're going into, just go ahead and start out and just, stay on the narrow path with that
mhm.
decision.
Yeah.
Because it's gonna be a challenge when you graduate and then you go into something that you don't love, and
Mhm.
then you're having those regrets, or you're doing these courses, paying for all of these courses, and then having to switch over like you're confused. No, it don't make no sense.
Yeah, that's
Mm-hmm.
so true. That's so true. If I was chasing money, I'd probably be a nurse anesthetist, but
Mm-hmm.
but
Mm-hmm.
that's not a good idea for me.
Mm-hmm. Mm-hmm.
Yeah.
Yeah, because most of the time you'll find persons, especially, when you have facilities that are offering like your little programs, the mental health, midwifery
Mm,
for nurses, they will
yeah.
choose from that time. And a lot of times you'll
Yeah.
find out that these persons still continue on that path. If it's a
Mm,
peds, if you did your certification as a peds nurse in those countries,
mm,
you'll come here to the States and then they'll do the peds nurse practitioner program. You understand?
mm,
And so you don't feel as though you wasted all of that time,
yeah.
doing those programs and getting the experience. So yeah, that's
Mm.
nice. Okay. So how is just give us an idea of how like your floor is actually set up.
Yeah, so we have it's a private hospital, it's not NHS.
Okay.
So it's set up like there's 3 wards, two male wards, one female ward. So 32 beds in the whole hospital.
Okay, that's not bad.
Yeah, and I manage at night.
Okay. So 32 beds in the entire hospital. So on one floor, how many nurses to patient?
1 to 5.
1 to 5, not bad. And you have
Yeah.
like, and those are individual rooms. Are those rooms like protected? You have some rooms that have like some sponge, like if the patient
Mm,
decide to punch on the wall, it wouldn't injure their fingers. Is that like how the rooms are set up?
no, not exactly, but there are like certain guidelines for like for example, there's no like toilet seats, there's no ligature points, there's
Mm-hmm.
no like things that would really cause risk or harm in
Mm-hmm.
the rooms. So yeah, so it's all like regulated. So it has to be regulated before it's approved as a hospital.
Mm-hmm.
Yeah.
Okay. Yeah, when I was in Maine, that hospital in Maine, they had
Mm-hmm.
a psych facility. So theirs was
Mm-hmm.
well, the bathrooms were similar to that, and in the rooms it was more like a mattress that had
Mm-hmm.
sand inside.
Okay.
Yeah, it was like something like it had sand inside, so you couldn't move it or anything. The walls were a little bit more protected.
Mm.
So if they punch the wall, it's not gonna injure your fingers. They had
Fingers, yeah.
cameras in the room,
Mm.
but it wasn't recording. It was just for, like if the lights are off,
Safety, yeah, yeah.
then you're still able to see in the room.
Mm.
Then there was, what was it again? We had security guards, police officers
Yeah.
there. That's the
Mhm.
same thing.
No, we don't have security guards. So that's a big difference between here and the US.
Mm-hmm.
Here we have to do what we call control and restraint training
Mm-hmm.
ourselves. So we do at my hospital, we do one called MABEL.
Mm-hmm.
So we're trained to like de-escalate physically and things like that. So we
Yeah.
put hands on if
Mm-hmm.
necessary.
Yeah, we did the one we did in Maine was, I think they have one called the SAMA course, but the one we did in Maine, I don't remember what it was, but it was more like a bit of a, fighting
Yeah,
kind of, but it was
yeah, a
for
little
more,
bit, yeah.
yeah. Uh-huh. And then so what about like if you have specific rules regarding holding patients? Because
Yes, yes.
yeah, so a lot of times that's why, I see purses always doing certain things with patients, and I always say that, when it comes down to restraints, that's always your last resort,
Exactly.
because if you have patients that die in a restraint, it's a big
Hmm.
problem.
Exactly.
It is a big problem. And like the 1 hour renewal, or the, what do you call it again, where you do the renewal for the orders, the 2 hours, 4 hours for adults. Those, you still have those, you have those in your facility?
Yes, we do. Yeah, we review it every 2 hours. Yeah.
Every 2 hours, like, yeah, I
Yeah.
used to hate it, but it's because
Mm.
you are aware of the, when it comes on to psych patients and restraints, or not even psych patients, but because you have patients that do get it for medical reasons, like, your patients that are intubated and all. Like
Mm.
anytime you have that going on, it's always like, okay, then let's check it. Let's just check it, because you don't want it to be a case where something happens. When you
Mm.
get a chance to go ahead and remove it, release those restraints, it's always
Mm.
like, you feel a little bit better, because
Relieved. Yeah, yeah,
yeah,
yeah.
you don't want it to be a case where something happens in those restraints. Okay.
Mm. Mm.
So do you guys do a lot of like injectables for your patients?
Yes, yes. So we usually give the injectable we usually give for de-escalation would usually be lorazepam.
Okay.
Yeah.
Okay, yeah, we do that with the combo. So they usually do, I think,
Mm.
about three.
Mm.
3. Okay.
Yeah.
And then in terms of, what do I call it again? Do you guys do, so that's like, so how is the room set, like, do you guys have like glass doors, or how is the room like set up?
Yeah, so we have you mean the nursing office?
The nurses.
Yeah, the nurse's office. Yeah, there's like glass walls, kind of
Mm-hmm.
windows. Yeah, yeah,
Okay,
so we
so
can see down the corridor, down both corridors, and there's also a camera set up in the office as well.
okay, so it's
Yeah,
not like in the middle of it's not in the middle of the building, in the middle of the department. Your office
it
is
is. Yes, it is. Yeah,
okay, okay. So then pay
yeah.
enough. Coming also, psych people always get enough money, because of all the risk and everything. They pay enough. They pay a lot of money over there.
Not here in the UK, no.
Okay, okay,
Not here in the UK. Not
okay,
very much.
okay.
UK standard.
Okay, okay. Because I
Yeah.
was kind of surprised the other day when I saw it. I was like, so why so many persons are going? I know, a lot of times you go there because the opportunity
Mm,
do,
mm,
arise and you need it. So we take the opportunity
mm,
and go there. But then I realized, like, is that what nurses in, the UK was being paid all along? Yeah.
yeah.
So do you wear the blue? Well, I know you say you're at a private hospital. Do you wear
Yeah.
that blue and white?
No, we wear tunic. Yes, we wear tunic, but mine is dark blue.
Mm-hmm.
It's dark blue, yeah.
Okay. So do you wear the
Yeah.
little hat?
No, we don't wear hats.
Oh,
We don't wear
okay,
hats.
okay,
Yeah.
okay. Because I
Just
know
a
in
tunic
Jamaica.
and black trousers.
Okay, okay.
Yeah.
And that's for psych or that's for psych?
No, most hospitals will wear some psych hospitals they don't wear uniform at all. But we wear uniform here. Like I do locum in another in a pediatric psych,
Mm-hmm.
and they don't wear uniform there.
Okay, okay.
Yeah.
So your floor is both for pediatric and adults?
No, 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 no. I work just with adults in my permanent job,
Mm-hmm.
and then I do locum in pediatrics.
Okay. Okay. That doesn't sound bad.
Mm.
Um, so on the night shift right now, how many nurses you have?
Um, so we have a low occupancy at the moment, so
Mm-hmm.
not very many patients in the hospital, but we've got in the whole hospital we have 4 nurses today, including myself.
Mm-hmm.
Yeah,
Okay. Okay.
yeah.
Okay. So what's you say you don't have police officers there, right?
No, we don't.
So what's your
We are the
response
police
time?
officers.
What's your response time if you have like a situation requiring like police officers? What's your response time looking like for them to show up?
Oh, for them to show up. Probably they show up quite quickly, probably within 30 minutes, depending on the risk.
Mm-hmm.
Yeah, depending on the risk, they just if like say for example the patient absconded,
Mm-hmm.
they would go out and look for the patient and things like that. If there's something happening within the hospital, they would come quite quickly and yeah, for example, we had one time at night we had 2 patients break in.
Mm-hmm.
Even when the doors were closed, they broke in. They'd come back drunk. They broke in. They destroyed the whole reception area.
Oh Jesus.
They
Mm-hmm.
made a mess. So the police had to turn up and take them away.
Okay.
Yeah.
So in terms of if you have like because I know you say it's a psych facility.
Yeah.
So like you have so for example you have emergency, you have a cardiac arrest on any of those patients. What
Hmm.
is like, how you guys normally respond with managing those patients?
So we have an alarm system. So for any emergency, we don't use codes. We
Mm-hmm.
have an alarm system where you pull your alarm and the whole it will sound everywhere. So it will be very loud and it will sound everywhere. So everyone would see the panel on the wall, see
Mm-hmm.
where it's coming from, run to that emergency. So we would deal with it as much as we can on site, but
Mm-hmm.
we'd always make sure we call 999 for the A&E as soon as possible. So they would arrive as soon as possible.
Okay. So you said the 32 patients, so the
Hmm.
32 patients in this facility, the A&E is a part of those rooms or
No, the A&E is a different hospital.
oh, okay.
That's
So
yeah.
so the once the patients are stabilized, do you have to get an ambulance to transfer them to that A&E?
Yes.
Okay, okay, okay.
Yes.
So the patients are not used, so they just stabilize them there and then you transfer them to a regular
Hospital.
a higher level. Okay, okay.
Yeah, exactly. Yeah, exactly.
So when you send out that, whenever you have that cardiac arrest, is
Hmm.
the ambulance not the ambulance service? Well, Does the police get a notification from the facility? Is this facility set up to have that alarm sent over to the police as well?
No, we have to call. We
Okay,
have
you
to
have to
call
call
because
them.
we're a private entity. We're not attached to any other hospital system. So we're
Okay,
not connected to the NHS, so they wouldn't get any internal
notification.
notification. Yeah.
Okay, okay, okay.
Mm.
All right, that not sound bad. That not sound bad.
Yeah, yeah. But
That
we
sound
always
bad.
pray not to have that
I mean,
in this.
uh-huh.
That's the last thing you'd always want. But actually,
Exactly.
in my 5 years, I haven't actually, in my 5 years of psych being on the psych ward, I
Mm-hmm.
haven't had a cardiac arrest. I haven't experienced cardiac arrest.
Mm-hmm.
I've just done it on training. Obviously, I do it every year, ILS, but
Mm-hmm.
I haven't had one before.
Okay, so you have to do the ALS. What are the certifications apart from your psych, your mental health certification? What else do you need to get
Yeah,
to?
so apart from the mental health bachelor degree, so I have ILS, which is BLS but more advanced.
Mm-hmm.
So I've got ILS. I've got, like I said, the MABO training, which is
Mm-hmm.
the control and restraint training.
Mm-hmm.
What else do I have? We do a lot of e-learning courses like CPD courses, obviously.
Mm-hmm.
And then we do a lot of like face-to-face training, like on for autism, trained how to deal with patients with autism. We're trained on what else? There's a few how to deal with people who tie ligatures,
Mm-hmm.
how to search a patient, how to search the facility, things like that. Yeah.
Okay. Okay.
Mm,
Okay. That doesn't sound bad.
mm.
Mm. What are like the most common cases that you see on coming in for your psych patients?
Okay, the most common would probably be schizophrenia, bipolar,
Mm-hmm.
depression, major depression, serious depression,
Mm-hmm.
EPD, emotionally unstable personality disorder, um, alcohol abuse, drug abuse. It goes a long list.
Okay, okay.
Yeah.
Do you have like a lot of overdose cases, like fentanyl overdose
Mm,
and all of those?
it
Yes.
would be they would go to general hospital for that initially,
Mm-hmm. And
and
then once
then
stabilized.
they'll come once they're stable, they'll come to us. Yeah.
Okay, okay,
Yeah.
okay, okay.
Yeah.
That doesn't sound bad.
So guess where I'm going? Just
Mean?
guess. Yeah. Yes, I'm going to
I tell you, you're not gonna
Maine.
have any regrets about that. You're gonna love it there. As I say,
Yeah.
the facility is that I was at. Like I haven't had any other facility that
Mhm.
has given me the experience and is as clean as that facility that I was at there. So I think you're gonna have a good
Mhm.
time there. And it's their psych facility is a very huge one.
Mhm.
So definitely you're gonna enjoy it. And probably end up
Yeah.
staying down there because by the time they finish, you probably go and do your NP
Yeah.
and
Yeah.
then continue in psych, and then you probably just get a job over that same facility.
Yeah. So I had to crawl back and ask for the position again because
Yeah,
I spoke to another.
sorry, you spoke to who?
I spoke to another nurse who works in that area, and yeah, a Ghanaian nurse. So yeah, I was convinced after speaking to you and speaking to him, I
Uh-huh.
was convinced. Yeah.
Okay, good, good, good. Yeah. Because as I say, like, with the training and for international nurse, I just thought it was a really good, that location was
Mm,
very good, or that hospital was very good, the
mm.
experience. And then when I started traveling, I'm like, huh, but this seemed like the best hospital, like, in the States
Oh,
here.
wow. Yeah, yeah. I got another offer.
Mm-hmm.
I got another offer for Mercy One in Iowa,
Mm-hmm.
but obviously I'm gonna decline that one. But
Yeah, I wouldn't go that
it was a
one.
no-brainer decline because it was number one.
Mm-hmm.
It was direct hire, which was good, but they were paying less, $8 less per hour.
Oh. Mm.
Yeah,
Mm-hmm.
so I decided. I will go for Maine.
Okay, yeah. Take the one in Maine.
Mm.
It's not gonna be that bad. You
Mhm.
won't have any Macy's up there though.
Any which?
Macy's, you won't have much places to shop. You'll probably have to drive a couple hours.
Oh
Unless they
yeah, a
probably
couple of
have
hours, yeah.
hmm? Unless they
Mm.
probably, have a lot of stores open up. But at the time they were closing out
Yeah.
everything. There's
Oh
bars there
wow.
though. They have bars down there.
The one thing I'm just apprehensive about there is the snow
Hmm.
and the ticks.
The ticks. Hey,
Yeah, I heard there's ticks in Maine.
yeah, there are ticks in Maine. There are bears in Maine. There are moose in Maine. Like some
Mm-hmm.
days I'd come outside and the only thing I'm seeing is like prints, moose prints at the back of my yard, at the front of my yard, at the door. I don't know if it's fox or whatever. There's so many things in Maine. But if you don't put yourself in the way off, you won't get it. I don't think
Okay.
you'll be going in any bush. So
Okay.
I think I've seen one patient with Lyme disease. It's not
Okay.
something, and then when you talk about the ticks, yeah, man, they have some
Mm.
big ticks. Like some patients will come in with the big ticks, but those patients, they have, they're working in the field. So you're not going to be
I
working in the
see.
field. So,
Okay, I see. I thought it was more prevalent than that.
no, I never get no ticks down there. Yeah, we have no ticks down there. But yeah, you'll see patients come in the emergency room with ticks, but if you
Mm.
don't put yourself in any situation to get ticks, you're not going to get any ticks.
Okay, that's great.
Yeah, it was beautiful down there. It was very, very beautiful. And depending on where you're gonna go, I would tell you look up this place called Herman. Herman,
Okay.
Hermon. That's where
Okay.
I spent my entire contract. Herman. Well, I shouldn't even probably say it on here. I'll text you. But
Okay, text me.
I'll text you. But that place, it was very quiet. The landlord does plowing every morning that, whenever it snows, ritually every morning. I never had to do anything. He has covered the garage. He has heated flooring, so that's always a plus, girl.
Oh wow,
Yes,
wow.
that was a plus. And as I say, a lot of places down that side, but it was probably like 15 minutes, about 20 minutes drive. Yeah, from the hospital to that location. And those places are like duplex. It's duplex. You don't pay for gas because that is a part of the rent. So you just pay your regular electricity bill and water bill. What else? Yeah, so it was pretty okay. It was pretty okay there. I did like it. And what else? Yeah, but definitely I would say that's the best place when I was looking around. There are other places, but they were a bit of a drive.
Was
But
that Bangor?
in Bangor, close to so it
Okay.
would be close to Bangor because Bangor is gonna be where the hospital is.
Yes.
Then in Bangor, you're gonna realize that the houses them not look good. It all, yeah, like it's the first. It seemed like one of those first place in Maine. So all the buildings just look a little bit old and all. So when I just moved here,
Okay.
that's where I was in Bangor, and the place it just seemed like to separate, to fall apart. So his
There's one I
duplex.
saw.
Mhm.
There's one I saw called the Exchange Building,
I really,
but
I
it's
remember
very
Exchange.
expensive.
I remember
It's
Exchange.
very expensive.
I'm gonna text you the address, but it was in Herman, Maine. But it was pretty nice. He had two locations, and he had, it was pretty good. It was pretty good. Never had any issues there. And then the back of the yard, like you can see the moose. You can see, like, especially
Oh
in winter.
wow.
In winter,
Yeah.
winter was beautiful. I'm not really a Christmas person because I don't really celebrate Christmas because I never used to get no gifts when me growing up. So Christmas
Oh.
was like a regular day.
Yeah.
Christmas was like a regular day.
Yeah.
We used to meet up with family members and just have, Christmas dinner, but it's not anything around this big long table and eating all of those fancy stuff. It was just like a regular day where we meet up and we just enjoy life.
Yeah.
But I never really grew up like, oh yeah. But I tell you, when I was in Maine, that was the first time I feel as though I wanted to celebrate Christmas. Because when it snowed, it was just like so white outside.
So beautiful.
Just like how
Yeah.
you see the Christmas movie. it was just like that. It was just so white outside, and then because the trees now not have no leaf on it, it's just like some little branches sticks out there. So whenever it's icy, it's just so glossy and it's just so beautiful. You look outside and everywhere is just like white and just beautiful, especially when the sun comes out and it's melting all of that snow off, and it just look like a clear glass. You don't want it drop on you, do you?
Wow.
You don't want it drop on
Yeah.
you, but it just looks so beautiful on those trees. Like there's no leaf, but the only thing you're seeing is just brown, the sticks on the tree.
Yeah.
And then it just looked like so glossy and beautiful. And then because you have not much houses around the place, when you look through, it's like just think of it like a wilderness. Alice in the Wonderland. You look through, and everywhere is just white, and then you will take a little time and see like little moose passing through, fox passing through. You'll see the deers passing through, and it's just beautiful. It was just so
Wow.
beautiful. I felt at that time I could feel my heart just like, just crying, because I'm like,
Oh.
is this like, is this really what Christmas is all about? The only thing I needed was Santa to come down and come to my
And to drop some
but it
gifts.
was
Yeah.
very beautiful. It was very, very, very beautiful. And then because there was like a little pond, so the not all the time it was like frozen. So the bears and everybody would come and just be drinking, drinking from there. But it was very, very beautiful. Down
That sounds
there.
amazing.
Yeah.
My husband, he likes like apartments, buildings with big views and things like that. But I have to try and change his mind for something else
Oh,
because he
well, you're
just
not
wants
gonna
an
find much.
apartment.
No, you're not gonna find
Yeah.
much like that down there. You'll find probably like the little
No.
homes and all.
Yeah.
But that was the best thing that was in that area, that was in the same drive-in zone, school zone if you have kids. Yeah, and so like it was Walmart was a bit of a drive, but they had the store called, what was it again? Yeah, there was a place like you can get a lot of organic stuff
Oh, cool.
there, but it was pretty nice. It was pretty nice there. I did love it there at that place. As I say, I spent my entire contract there. And that was it.
Yeah, I'm excited now. I think I'm gonna finish my contract there as well.
Yeah, don't break your
Yeah.
contract. Don't break your contract. Just
Yeah,
finish
no,
your
I won't do that.
contract and just call it a day. And then
Yes.
from there. But it was beautiful. As I say, and they saw the road very, very frequently. It's not like probably, well, in Texas here, whenever the little snow comes down, everybody go on break. It's like an emergency here, so nobody wants to drive. In Maine, it's constantly being salted, so the road
Okay.
system is
Well
always
prepared for it, yes.
It messes up your car and feel good when you're driving, but you can still do your thing there. So it wasn't bad. It wasn't bad. Yeah.
I'm so excited.
Yeah. The only part I
Yeah.
never liked was the blizzard. And as I say, if it is, usually the hospitals will make accommodations. They'll have places for you to stay. And if you feel as though you can drive it, then fine. But they usually make accommodations at different hotels or on the hospital compound from the night before
Okay.
for you to stay and then go home in the mornings. But I never spend any time at the hospital. I
Okay.
never spend any time. Every time that there's a blizzard, no, I drive home.
You drive.
And
Okay.
so-
And it's okay to drive.
yeah, it's okay to drive.
Yeah.
It's okay
Okay.
to drive. As I was saying, do not buy. Well, you can buy things. You can go online and look up LL Bean. LL Bean has really good clothing supplies for Maine. Yeah. So it's gonna be a little bit expensive, but if you buy a jacket, you just know that if you're gonna be there for 2 years, you buy a jacket and the jacket is for a temperature of -30, you will be fine. Spending $200 or $300 on a jacket that is gonna last you a lifetime. Yes, it will be
it's
worth
good.
it.
Yeah.
So LL Bean has really good jackets and they have lifetime warranty on their things. So definitely check them out if you're going to be going to those places, because as I say in another video, if you buy something in another state and even though it might say it is good for this, it might not be good for the weather in Maine. So you want something that is going to be fitting for the weather in Maine. So LL Bean has really good shoes and jackets and everything for that temperature.
Oh,
Um,
brilliant.
yeah.
Brilliant.
Yeah. So I'm excited that you'll be going that side. I'm excited
Yes.
that you'll be going that
Yeah.
side. And their charting system is good. They use
Okay.
Cerna or Oracle.
Sona. Okay.
Yeah, they
Yes,
switched
that's
over
it. She
to.
mentioned that. Yeah.
Okay.
Yeah.
They have really good charting system, and their continuing education courses are pretty good. They were paying for that as well. Like if you do 4 hours, they pay you for that.
Oh, okay.
So
Mm.
what else? But it was pretty okay there. It was pretty okay. Wasn't a bad system. Wasn't a bad hospital. I say it's the
So
best
why did
hospital
you
I've worked.
decide to move?
Girl, I'm from Jamaica. Let me stay in the snow though.
You like the heat.
Yes, I can't do snow. I cannot do snow. I cannot do snow. So I got the contract. Initially I thought it was gonna be, you know, when somebody tell you that the temperature is like 40 degrees, you're like, oh yeah, 40 degrees is not bad. But when you go over there, 40 degrees and you will just 60
Cold.
degrees. It has to be 70 degrees or more. I can do 65, 60. It's not like so bad, 50s, but I can't do 40s for the entire year. You understand? Summer, they give you summer, and then you see everybody coming out in their shorts and sleeveless, and the temperature outside is like 45. Me still in my jacket for the entire summer because the temperature is not
Yes.
going up that far. Probably you'll get like, a few days of temperature in the 80s, and that's it. But apart from that, it wasn't my cup of tea there. I had to find something that's going to be a little bit warmer. But in terms of the contract, it's something that I can commit to. And so that's what I
Okay,
did.
okay. I'm used to that weather being in the UK, so
Well, yeah, if you're gonna be,
yeah.
it will be fine for you. It will be fine for you. I don't know in terms of the shopping, like, things that, as I said, there was an African store in Bangor that had, a few things. So
Okay.
if she's still there, there was a Jamaican guy who had a restaurant, and that's the best Jamaican meal I've had since I've been
Oh,
here in the
wow.
States. Yes.
Yeah.
He was in Bangor, and then he moved to another place called, I don't remember that place, but it was like 1 hour away from me, where he moved to. But in terms of the jerk chicken, the oxtail, the curry goat, yeah,
Oh,
man,
yes, we love Jamaican food.
I ordered
Yeah.
those and put it on my fridge because what else to do more than work and eat, so
Exactly.
that there was one Jamaican place. They have like their those food market, what do they call it again? Craig Lee said cook. Yeah, man, me can't cook, Craig, but me I tell you, so when you're in them places there, a lot of times you don't have the energy because the place outside cold, and what else? The place is just cold and just feels depressing. So me not really, yeah. And plus his meals weren't that bad because they were selling oxtail, and the oxtail the long from here to Jericho. I mean, I go home and try to cut it up, and it never work out because they were cutting it up because they say it damaged their blades. So when they cut it, it was like this long. So it couldn't fit in my pot. You understand? So it was like a total waste because I had to be trying to cut that thing, and that oxtail, it's very, very hard. It's very, very hard. So I just go ahead and order it from him. So I'll order probably like say 10 servings and just put it on my fridge. Already cooked. So that was just it. But yeah. But the place up there
I was
wasn't
told
bad.
there's an African shop in Portland, but that's far, isn't it?
Yeah, so Portland was where I would normally drive. Portland was 4 hours. Was roughly around 4 hours from where I was. And I would go down there and get certain things. So yeah. And then like I would drive into Boston to, if you need to back doing a little shopping, you can drive into Boston. But Portland would have given you a few more things. They had like the Macy's, they had a Bank of America down there. So they had a Bank of America down that side. They never had any in Bangor. So what else they had? Yeah, Bangor just had like a lot of places like, antique shops and all. And, if you go drink a little something in the morning,
Yeah, you'll
Mm.
find out that the folks there are gonna ask you if you want to go for breakfast, and when you go for breakfast, everybody gonna drink.
What? In the morning?
Oh my word! When I just moved there to say, Stacey, we're going for breakfast, I said, okay, no problem. So I thinking that breakfast, cause my breakfast usually can be like a bread, egg, dumpling, fried dumpling,
Mm.
whatever it is, Jamaican way. But now you come to America and you're thinking that breakfast is gonna be something more, it's gonna be probably bagel and egg and what else?
Yeah.
Yeah, I don't even know what they have on big breakfast because I don't really eat breakfast out like that. But yeah, I thought it was gonna be something else, orange juice or apple juice or something. It was a bar, and I don't
Papa.
drink, so I just tell the
There.
folks, I'm like,
In the
it's not
morning.
working out. They say yes, this is what we do in the mornings. I'm like, this early. But yeah, you'll find that they're very they like to go out and whatever, but it's not my cup of tea. Not my cup of tea.
Yeah.
But they will tend to have a lot of parties and whatever. But it's all
Mm.
about going to the bar and just hang out. Like,
That sounds very Irish because I grew up in Dublin,
uh-huh.
so they love pubs, like
Yeah, you'll
bars
find
all
out
the
that there's a
time.
lot
Yeah.
down there. A lot down
Mm.
there. And I guess because the place is so cold as well, people don't have anything else to do more than just find one of those little bars and just warm up
Sit and
their
drink.
heart.
Yeah. Yeah.
Oh, and remember when you go down there, remember that everybody takes smoke breaks. So even if you don't smoke, just let them know you're gonna be doing your smoke break as well. All right,
Oh,
because if
brilliant.
not, huh?
Brilliant. Yes. Yes, I will.
Yeah, if not, you will realize that you're only getting your 30 minutes break when everybody else is getting 1 hour break because every second you hear that they're going on smoke break. So I started,
Mm.
once I kind of understand what was going on and I was comfortable with certain things, me start telling them to make up on smoke break too. You
Yes.
understand? But they know you don't smoke, but they will just say,
Mm.
okay, Stacy, and you're just going to take your 15 minutes as well. Because it's only fair because in the state of Maine, you do get 2 15 minutes,
Okay.
30 minutes of is it paid?
Paid.
How it go again?
Mm.
You get 2 15 minutes. I think it's like free. It's a part of whatever, the union.
Okay.
So you get 2 15 minutes break plus your regular unpaid. So you get paid and
Unpaid.
unpaid.
Unpaid is an hour? What was that?
Huh?
Unpaid is an hour?
No. So the entire break you'll get is 1 hour. So 1 hour
Okay.
with the company, 30 minutes with the company, which is your unpaid.
Mm-hmm.
And then you have 2 15 minutes that the union says that you should get for, when you're working your shift. So in total, 30 minutes and 30 minutes. So you have a 30 minutes unpaid and a 30 minutes paid, which is going to give you 1 hour. But nobody really tells you about the paid, the 2 15 minutes paid.
Mm-hmm.
Yeah, they don't tell you about that. Is when you go and read the book, you'll realize that, oh, you're entitled to it. So you just let them know that you're going on a smoke break or you're taking a 15 minutes break and that's it.
See.
And I think you also get if you're pregnant, if you're nursing, I think probably at other facilities as well. You get, I think they have different times that you can go ahead and do. They have rooms where you can go and express your milk as well. I think that is like paid as well. So yeah,
Okay.
so make use of those little things that they have.
Very good. I have a bit of a dilemma though because I'm going to accept the offer. Well, I've accepted it already. She just hasn't got the email because it's she has to have to wait till Monday.
Mhm.
But they've given me night. I know I am a night nurse,
Mhm.
but I want to go. So I probably will switch back today, given that the breaks are not very long, because I'm
Mhm.
used to at least an hour and a half.
Oh, Jamaican style,
Yes,
girl.
yes, yes.
So, well, what's the reason for not doing nights?
Yeah, so I've been doing nights for about 3, 4 years now,
Mm-hmm.
and it's taking a toll on
Oh,
my health. Yes,
oh,
yes,
okay,
yes.
okay.
Yeah.
So, okay, I understand that. But for
Mm,
me, I think the night shift, when you're transitioning, for me, the night shift was something that worked out. Like you do the orientation on days, but the night shift worked
mm-hmm.
out fine because you realize you don't have that much, it's not that hectic on nights.
Okay.
So it was fine for me on nights. But for you, to each his
Mm,
own, if you're having that going on, then I understand.
mm,
But night shift was
mm,
okay. Wasn't that busy where you had like a lot of staff or managers coming around and the
mm.
entire thing with teamwork and everything.
Yeah, yeah,
It was a little
yeah.
bit.
I'm also used to days because in my last job I did night and day.
Mhm.
So I'm used to the workings of the day shift as well. But I think
Okay,
it's just better for me
for
to be
you.
on day shift. Yeah.
Okay. You can talk with them and see.
Yeah. Yeah.
Okay. Yeah, because most of the time they will hire, like most of us that came up on the contract, they put on night shift. A few persons, like a handful of them, do get a chance to go on day shift.
Mm,
But most of the time they will be hiring for a night shift because some
a night
persons, if they have a
shift.
day
Okay.
shift open up, then
Mm,
they will say they will open it up to the staff there, and then you'll realize some persons jump from nights to days.
mm,
And then from there. But their shift differential was, well, you're gonna be on contract, but their shift differential up there wasn't bad.
mhm.
Shift differential wasn't bad. hmm Yeah, but it's gonna be okay. hmm
2 years waiting now.
Hmm?
2 years waiting. Yeah.
Huh?
Retrogression. 2 years waiting because of retrogression, though.
Oh, okay.
Yeah, yeah, yeah.
Okay.
So I'm at the 2.5, almost getting to the 2.5 year mark.
Mark. Okay.
Yeah, but it will happen soon, hopefully.
Okay. Okay.
Mm.
Well, I'm hoping that will happen real, real soon.
Oh,
hmm Okay. Alicia Ashanti, welcome. DJ Super Sham, One Bad Driver, Danjoma. Craig, where are you joining? Portland, Maine. Yes, that's Portland, Maine. Yeah. Um, where are you joining from, Craig? Dudley. So what time is it now for you, Nurse CMs? It's 11 o'clock.
it is 5:09 in the morning.
Oh, okay.
Yeah, shift
I'm here,
finishes
yeah,
at
yawn
quarter
it.
past seven.
Eh?
Shift finishes in 2 hours.
Okay, hold on.
Mm.
Okay. Yeah, man. Usually them time here when I'm working night shift, 5 o'clock in the morning. Well, is it five? No, 5 o'clock. Is this time my eyes kind of, I open them back up.
Mm.
Yeah, because like 2 o'clock usually kind of get a little bit quiet, and then it's like the place just
Mhm.
so cold because nothing much going
Yeah.
on, and I'm just like
Mm.
yawning, yawning, yawning.
No, I keep myself awake with a cup of tea or two.
Yeah,
Not great, but
yawning.
yeah.
And then by 5 o'clock, no, 5 o'clock, I'll be like, okay, then 2 hours to go. The sun is gonna be coming out soon. Not in Maine,
Hmm.
not in Maine, because the sun not coming out like soon. You understand? So
No.
in Maine, it's a little
Yeah.
bit different, but
Okay.
otherwise, I'll
Mm.
be like, yeah, it's time for me to kind of wake up now. So, I'll be getting my body ready, and
Yes.
yeah. But the time between 1:30 and 4:30, I think it's
4:30,
a,
yes.
I think it's a mind
Mm.
thing as well. It's a mind
No.
thing, yeah. It's a mind thing. Just know that it's time to sleep because nothing going on, and then 5 o'clock, it's time to start waking up. But
Yes.
it's not that bad. But yeah, in the time, like whenever it's in Maine, that was one of the biggest thing I never like morning. So in the evenings, it starts getting dark from probably like around 3 o'clock, 4 o'clock.
Oh, wow.
Yeah, like that was the part that I never like. When I just moved there, 3, 4 o'clock. look like 7 o'clock in the evening. Well, you're not from Jamaica, but yeah, it was kind
Is that
of.
the winter?
It was September. I went on there in the September. And I'm like,
Mm.
yeah, because I was surprised when I looked and the time was like after 4, after 5. I mean, I said, no, sir, this is depressing. This is already
But is
depressing.
the summer brighter, isn't it?
Summer is a little bit brighter.
Mm.
And then like 9 o'clock, sometime all 9:30 outside look like probably like 3 o'clock. Yeah, so you have to just know that, okay, then it's 9:30, so it's time to go and sleep. Because if you follow the time up there, you will be up and you don't get any rest for your shift in the morning. Yeah,
Mm.
so you have to be watching the clock like a hawk. But I never really like it because the time was just something I couldn't work with. Like it gets too dark early, and then in the summertime, it's too late. The sun goes down too late because 9 o'clock outside is looking bright, just the same.
Yeah. Same as UK.
Okay. So I never really like it, and then after a while, you kind of get used to it. Used to it. But then you will realize that whenever the sun goes down too late in the night, you wake up very, very tired. Very, very tired. So I'm going in for work and I'm like yawning because I'm like, no, sir. Never like it. But apart from that, the sunset were very, very beautiful. And the Northern Lights was beautiful. Yeah.
Oh, wow. Okay. I never thought about that actually.
Yeah, you look in the sky and you're seeing like orange and green and purple looking like
Ooh.
blue. Yeah, it's beautiful. But yeah, apart from that, they have like, what is down by Maine for you to enjoy. Bar Harbor is there.
And they said there's a lot of outdoor activities.
Yeah, they'll invite
That's
you
what
for
they say
fishing.
to promote it. Yeah.
They'll invite you to do fishing and
Oh, fishing. Okay.
hiking. I don't hike. I don't hike. I don't go no hiking with nobody. But they'll invite you to
Me
go
too.
fishing and hiking. Yeah, and the fishing is gonna be you go and fish on the when the lake is frozen. That's when they go and they go fishing as well. And they'll dig like a hole in the river. Like, the lake is actually frozen. And then they'll go and sit and start drinking and then wait until whatever happen. And yeah, I don't have time for that. It's not no like, regular. I guess you can do that during the warm time. But sometimes you'll see they invite you fishing in the winter. And they dig through the ice. Yeah, dig through the ice to set trap for the fish, and then they go and sit in a little hut and laugh and until they catch a fish. No, but I don't go hiking. I don't go hike. I'm not going no hiking. I didn't do any form of hiking when I was there. And I did go to Bar Harbor, and Bar Harbor you can do whale watching and all. And they have some really nice food. Like, yeah, they have food down there you can eat. You have a lot of Jamaicans down by Bar Harbor working in the industry, especially in the summertime. There's a tourist attraction down there. It's beautiful down that side.
My family will love it when they come to visit because they love outdoor activities.
Okay.
Yeah.
What else is in Maine? And they have, as I say, you can go and do your walks and all, but yeah. And what else? They have some zoo that you can go as well.
Okay.
Craig says he was there in 1999. It was nice there. Okay, nice. Yeah.
Very nice.
They have a lot of lobster down there, so they're well known for their lobster. And what was this gentleman's name again? There's 3 things Maine is known for: lobster. What's the mayor? Is the mayor? What's the lady's name? People always making fun of her. And there's a writer down that side.
Okay.
So the first time that they would say, "Oh, I saw like some persons at this house," but I wasn't so sure what it was because the place is just like covered. It was at the time when I went there. It was in the fall, so a lot of the trees was losing the leaves and everything, and like it was like a ton of like leaves on the floor on the ground. So you're driving on the road, and if you're driving too fast, just like in the movie, and you're looking behind you, and you just see all of these leaves just up. It was just like so
Flying, yeah.
beautiful. So, anyways, I found myself like up to this house, and that's where I first got lobster and fries. Okay, I found myself up by this house because there were persons taking pictures. And I was like, what are they taking picture of? Because there's nothing beautiful over there. Like, no disrespect. It was just like brown or looking like red, like the gate. And it was just like nobody was over there. People are just standing, taking pictures. And I'm like, okay then. But I never really see anything fascinating like to take pictures of. But there's this writer that is from Maine, and that was his house. And I was like, okay. But it was in Bangor. Let me tell you what his name was. But he's a very famous writer. So famous writer in Maine. Stephen King. So they'll always say, they'll say Maine is known for Stephen King, lobster, and what's the lady's name again? What was her name again? So 3 things they would say. Maine is it's not that one. There's another lady. I want to remember her name. Yeah, but I think she's a Democrat. She's a Democrat.
Okay.
So they'll say these are the 3 things. Maine is known for Stephen King, lobster, and that lady's name. Yeah.
That's good. I love lobster.
So you'll get a lot of lobster down there. I don't do lobster, so it was the wrong place to go. But as I say, in the summer, and then the summertime, is it summer? So fall is going to be beautiful as well when the leaves are, trees are losing their leaf, and then you have, springtime, you'll see different colors. Because all this time, sometimes I would say that, you'll see red leaves. Yeah, you'll see different color leaves, and it's just going to be so beautiful. Just like how you see sometimes on, in books, and you're thinking that, oh, no, tree color look like that. Trust me, you're going to see the different colors up there, and it's going to look so, so beautiful just driving past, and you're seeing like red, purple, brown, pink, orange, you name it, it's going to be there. Yeah, so it's going to be very, very beautiful there. So winter is beautiful, and it has to be like, winter for me is going to be whenever you don't touch the road as yet. Because when they start messing up the road, it's going to be, like on every corner, you're going to see like snow plowed and
Snow.
but whenever you go out and you're the first person, out there, and you just see everywhere just covered, looking so beautiful, you're going to enjoy it. You're going to enjoy it. But summer is nice, fall is nice, and fall is nice. But the roads are always going to be covered with leaves. But it was beautiful because, as I say, because there's not much cars, so when you're driving on those roads and it's already covered with leaves, because nobody's like clearing off the road like that, because there's so much trees in Bangor or in Maine. You understand? There's so much land space, but they're not cleaning up the road like that, like in some places you probably go. So the road is like gonna be covered with leaves. But when you just press on that gas and just go through, and you're looking back, it's like so beautiful.
Beautiful.
It's so beautiful. So you're gonna enjoy that. And
So I wanted to ask about getting the car finance. So I've been driving a very small car for a long time now. So I want to get myself a nice Lexus.
okay.
Yes. So I'm thinking of a Lexus, but I don't know whether to go through International Auto Source
So that was one of
or
the companies that my company was sending us through.
or to go through a credit union.
So at the time, because I was in the, because I guess because you're not in the state as yet, they were giving us the opportunity to use the International Auto Source. That's what I'm thinking. But when we
Okay.
got here and we signed up with the credit union, most persons went through the credit union.
Okay.
So it depends. But I would say if you're probably looking for that, I would say go through the credit union because then you'll be able to build the credit, get credit score going because you'll be paying
Okay.
for a loan.
Okay.
And then the other thing, I know Lexus is a very good car. Is it like a 4-wheel? Because as I say, you're gonna need something that is gonna be very good for the snow. So did
Yes.
you
All
research on
weather
that
drive.
already?
Yes.
Okay.
Yeah. All weather drive. Yeah. An SUV.
Okay. So definitely, I would say go with the credit union because then you can build on your credit score while you're doing the payments on that. I guess probably you can still build on your credit score through the international, auto source, but I don't know if they're going to be offering you any credit card. You want something that is going to give you more,
Okay. I see.
benefits.
Yeah.
So you look at your credit cards, you can get a bank account, you can get your credit, your car loan. That's 3 things you can get from them. So that's going to be a plus rather than just getting the car through International Auto Source and then be paying them. It goes towards a credit, but if you could have gotten a credit card at the same time, that would have been a plus with a credit union.
What credit union do you recommend?
So that I don't really know which one I would recommend. So the thing is, when I got here, the company had Advantial. That's the one that I signed up with.
Okay.
So that's the one I signed up with. So that's the one I still use. I never had any problems with them. They're the ones I got the car loan through, and I did the credit card through. And I never had any problems with them. Pretty easy to get through to. I think, as I say, in Maine, they had the closest Bank of America was in Bangor. So if you want one, you're gonna have to go all the way down to Bangor. But the thing about my company was that when I was in Florida, they went ahead and get me signed up with Bank of America from Florida because they know that a lot of these places are country area, so you might not have there is a TD Bank though. There was a TD Bank in Maine. There was a TD Bank in Maine. Did they do Zelle? I don't know if they did Zelle at the time. I think they did Zelle. Yeah, but I know there was a TD Bank in Maine and in the Bangor area. But most of the things you'll find are gonna be in the Portland section.
Let's see. Okay.
So credit union. What credit union was? I don't know if TD Bank is a credit union, but I know there was a TD Bank somewhere up there.
What time are you at over there now?
11:25.
Oh, late.
11:25. Nurse Shanika, welcome. Escobar, welcome. Debbie. How will this may invite? Well, Maureen. This thing is like so tricky. As soon as you touch on something, it just send out a request. Okay. Yeah. That wasn't bad. What else I can tell you? And then, as I was saying, regarding like if, say, for example, your husband needs a vehicle, you can always just let them know that you're with, because both of you are on basically under the same company with the filing. So you just let them know you're with that company and they will go ahead and use the same company's information to go ahead and get him approved for a credit card as well as for the car loan.
The car loan. Okay. So we can have 2 cars.
You can have 2 cars.
Yeah. But I will have to do driving lessons because we drive right hand here.
Yes.
Yeah. So
You're
I
gonna have to
need
do
driving
this.
lessons.
I never did any driving lessons when I got to Maine because I had the company had us do driving lessons and get our license in Florida and then transfer it when we got there. But you're gonna have to go on the road and do the exam for the DMV in Maine if it is the first time. Mm-hmm.
But my husband, he drove left hand, so
Oh, so it should be
he'll be
fine.
driving me to work initially.
Okay. Mm-hmm.
Yeah.
What else? And the good thing about Maine is that you'll get a compact license. You get a
Yes.
compact license, so that is going to be a good thing
Mm.
about them. When you
I have a
just
Texas license.
who you?
I have a Texas license.
Okay, okay, but it's not
Yeah,
compact.
so it is. I think it is.
How?
I think it is. Is it not compact? I
Uh-uh.
thought it was compact.
No. So the state is compact, but you have to you get your 1 year, and then you have to go ahead and after apply for the compact.
Oh, I see. I
Yeah, so
see. Okay.
you get single state, and then you have
Mm.
to verify your address where you pay taxes, and then after that you can apply for your compact. Because initially I thought I was
Okay, I
getting a
see.
compact when I got here, and after I
Mm.
got my temporary, then I realized they sent me a single state. So when I call them, I'm like, "What's happening?" And they're like, "Yeah, you have to apply for the compact state."
Mm.
Not like mean that you do your exam or you transfer and you get to your compact. You have to do that.
Oh,
Yeah.
okay. I didn't know that.
So that's just the difference. Texas is a little bit different with almost not everything, but a lot of the things.
Mm, mm.
Lats 345, welcome. Yuli Clark, welcome. Thank you guys for tuning in. If you don't mind tapping up the live.
Tap, tap,
Tap,
tap, guys.
tap the screen. I hear somebody was like on their channel, it says tap the screen. Tap the screen. One of the DJs, this thing is like tap the screen. I was like, okay. Yeah. Tap the screen. But yeah, it's not gonna be bad. What else? So definitely it's gonna be it's gonna be very good up there.
So I'm thinking of getting my social media accounts up again. Because
That's what
obviously
I was
there's
gonna
nothing
tell
on my
you.
page. There's nothing on my page, as you can see.
Uh-huh.
But I'm thinking of maybe doing when my process kind of gets kicking off, start some nursing content like vlogs, do some lives, just showing my process of moving and everything.
Yeah, you don't have to wait until then. You just can start from
Okay.
now. Yeah, don't wait
I
until then.
know, I
Go ahead
know.
and
I
start.
always get making excuses.
Yeah, when the information is fresh, just like how you getting the information now, you can start with how you start
Mm,
with, your application and what you're doing in terms of
mhm,
getting your car sorted out, all of those information. Just go
mm,
ahead and start posting. And,
mm,
so that way, by the time you get to that part, you'll be a little bit more comfortable with the camera. The words will be
yeah.
reeling out of your mouth, and you don't have to be like, apologizing for something probably that you never wanted to say. So you'll
Yeah.
be a little bit more comfortable with it, and then you'll be able to show. That's the thing I wish I had at the time. I wish I was a social
Mm,
media kind of person, and I was
mm,
able to. I was always like recording things, but I never really posted them.
mm,
But I wish I had gotten all of those clippings from my time there. I did have some, but they're not that long because they were like, you see the lake froze and you just go ahead and record the lake for a little time, or you see freezing rain,
mm,
you start, recording freezing rain. Like when it comes down on your
mm,
windscreen, it's actually frozen. So things like
mm,
that, I wish I was thinking about doing from that time, doing more, scenic, views of
yeah.
the places that I was at.
Mm.
I wish I had done most of that so I could have them for content. But seeing that you're going to be there and you have your TikTok here, go ahead and just put up everything.
Yeah,
Content is
yeah.
content. And then, especially if,
Mm,
you have persons who are not familiar with certain places and,
mm,
you showcasing some of those, it's going to be a beautiful, it's going to be a beautiful thing for persons to see in
mm.
Maine there. So definitely, I would say do that.
Yeah, I'm the kind of person I have so much content on my phone, but it's just for my phone.
Girl.
It doesn't go anywhere. So much good content though.
Yes, what you need to do
Yeah.
is just upload them. Just upload them. Take them
Mm,
off your phone. That's what I do on my YT page. As I say, follow me on
mm,
YT, people. All right. Follow
yes.
me over there at Think Nursing. One word.
Mm-hmm.
I share nursing travel lifestyle. All right. And but I just record and just upload the
Mm,
content. And you might find out the content that you don't spend a lot of time on is the one that the people them love. Yeah, man. The ones that
mm,
you don't spend a lot of
mm,
time on. So that's why sometimes I feel as though, oh my word, what am I doing? Because the ones that
mm,
I spend the time to produce is like I'm not getting the views. And then the ones that are just
mm.
like, just raw,
Do
authentic,
randomly.
is the ones
Yeah,
that people sit
yeah.
down and watch. And I'm like, are you kidding me? Are you kidding
Yeah.
me? But I still upload it either way because there are persons there that's still going to be watching. So upload it so that way by the time you are a little bit more comfortable and you have all of this traffic over to your channel, they'll be
Mm,
scrolling through. They have content to sit down
mm,
and watch for
mm,
days. So I
mm,
upload them,
mm.
even though, I might not be getting the views because later on, I see myself with 4 million followers, subscribers.
Oh yeah. Hmm.
Speak it
Yes,
into
why not?
being. Speak it into
Yes.
being. Yeah, I see myself with 4.0 M on YT.
Mm,
I'm speaking it into
mm,
being. So definitely, I'm just uploading my content and just leaving them there. And once I understand social media fully, people will have content for days to just watch. And that's what you must do. Just go
mm,
ahead and upload them and leave them there. People will come over
mm.
there and see. They'll find something over there. Every
Yeah.
every channel or every person have something that is unique about their
Them,
channel,
yes.
their content
Mm,
that is gonna,
mm,
have persons gravitate to them. So you don't know. You might
mm.
just be the viral
Yeah.
sensation that they're waiting to see because of
Yeah,
what
I
you have
tried in the
snap on the feed.
past. I tried in the past, but it didn't really kick off for me because I wasn't very consistent.
Yeah.
So I tried to use the fact that I'm a UKRN and
Mhm.
Irish RPN and
Mhm.
also have my NCLEX as well
Mhm.
to like kind of start a page. I called it USRN Consulting and but
Hunt.
I wasn't consistent. USRN Consulting.
Oh, okay. Let me look you up.
Yeah.
Yeah, the thing about it, I realize, see, if you're not talking about certain things, people don't watch your content. You see, if you talking about nursing, people don't really want to hear about that. They want to hear
Mm.
about things that are juicy and sweet, not
Oh,
mango
I
soul.
see. I see.
Yes, that's all we are. You understand? We want to hear other things that, I don't want to hear about no depressing nursing work and all them stuff there. They want to hear about other things. You understand? So when you have a niche, sometimes that is the problem. When
Mm,
you have a niche, it kind of put you in a situation where it feels as though you're not, progressing because the content that you're producing, people are not interested. So
mm,
if you are, and that's why, on my channel I try to not only focus on nursing. I talk about my story
other
growing
stuff,
up.
yeah.
I put
Mm,
things there that will still get one and two other persons interested in something on my content, and eventually they will go ahead and listen to my nursing content. So I
mm,
showcase, like,
interesting.
things like traveling in Jamaica, me eating a mango or
Mm,
something like that, an apple and it not taste good, going to the beach.
yes,
But I'm not showing up my
yes.
body and all them stuff, coming I have the Kim Kardashian
Yeah,
body
yeah.
and all them stuff if you show up. Even though I don't want to show up them stuff there because I want it to be still a platform that is, friendly and,
Yes,
educational and
yes.
all. But I still want it to be a
Mm.
case where you can come over there and sit down and laugh.
Yeah, have a bit of
So
fun, yeah.
the nursing content is there, and I'm showcasing
Mm,
a little bit of a Jamaica or me going on a farm or something like that. That's what is on my page. But when you
oh,
have
I
something that
see.
is a
Okay.
mixture, I think you will
Mm,
draw more persons to your platform. When you're a little bit more tied into a niche, even though that's what you really want it to be, you want it to be a specific niche
mm,
and just produce content.
mm-hmm.
Sometimes it can be boring because that's what I think people, look at my channel when I do talk about, nursing this and nursing that. I'm saying, they don't really want to come and hear about no nursing, depressing, nothing. You have persons who
Oh, I
definitely want to talk
see.
about or hear about your transition experience or hear about certain
Yes.
things, and they'll come.
Mm-hmm.
But for majority of the people, nah, they want something that is going to encourage them, entertain them a little bit. And so I just mix it in. And that was my intention, to mix it lifestyle, travel. But at the same time, lifestyle is not going to be about what's happening in my bedroom. It's going to be about things that will still, encourage you. What I do as a simple nurse practitioner, going to work, my makeup routine, even though, there's nothing really big about it, or how I go about with getting my hair done. So things like that, simple, straightforward. There's one person that might like it, so that's just it. So
I think I might take the 20,000 pictures and videos on my phone and start to do something with them.
And then what you should do is go ahead and upload them as a shorts. So start out with shorts and just grab people over there. Even though with shorts, I feel as though you don't, people, the attention span, just like on TikTok here, the attention span for people is like, say, 30 to 60 seconds. Anything over that is like, you just continue talking, because that's how I feel with my content. Because I share long form content, but it's more for both platforms. So when you do upload that, you will get the traffic over there for your shorts, but you realize you post a long form content that you spend the entire day, making. You realize that you only get 2 views on it, but your shorts is saying you get 14,000 views. And then you get 20 subscribers from that shorts, and not one of them don't watch the video that you posted that is like a 10 minutes. So it can I feel as though it can mess up your channel as well. So you have to be very, very careful. But I just feel as though you still get the followers, but they become so inactive because they're not interested in long form content, or they're not interested in the content that you're sharing. They're more interested in seeing a 30-second video, and that's it. So it takes a longer time for you to reach, like, getting monetized, because you have so much shorts and you're not getting the watch time on that, versus, you wanting to get monetized and getting your subscribers to watch and keep your page really active with the content that you're doing in your long form. But, so that's just it. So right now I'm kind of trying to rewire my channel, rewire it, because I have so much content over there. And it's like I feel as though I have so much on my hard drive that I don't know where to put it. And it's so difficult to upload them, because you have to, on that platform, you have to type in, you have to put in so many things in it for the algorithm itself to pick up your video and try to push it to the right person. But because it's so much, content creation is so much, sometimes it's just so depressing, and it's just so hard for me to balance getting the videos edited and putting in the right words and on label and everything correctly, and then upload it. So that is the biggest challenge I find. Hold on, may I talk to myself? But anyways, I think she probably come back on the page. But as as I was saying, that is the biggest challenge I'm facing right now on that page. But if you are interested in content creation, I would say go ahead, whatever videos you have in your phone, go ahead and upload them. Start off with shorts, start off with your shorts and everything, and get people coming over, and just be you. You don't have to come over and, be fake. People don't really like fake people. I don't really like fake people. You understand? If you're going to smile at me, I want to see a genuine smile, or no smile at all. And that's just it. But just go over there and just be yourself and produce your content. People will like it. And as I say, even if you're not getting the views, there is one person or 2 persons that are going to be watching it, and that should encourage you or motivate you a little bit more to continue producing your content. And if you have consistency, it will eventually work out. But, as I say, content creation is a lot of work. On TikTok here, it's not that bad. But on YT, I feel as though it takes my entire day. Yeah, it will take up like 8 hours just to produce one little content. And it's not even producing the content, it's just like uploading it and making sure you're using the right keywords and all of those things for persons to actually see those videos. But I do want to thank you guys for hanging out and tuning in. Even though I'm not seeing the little hearts coming up, I don't see the hearts coming up. Well, I'm at 8,000. But thank you guys for tuning in. Josh, welcome, welcome. Vern's Bracelet, Paul, Courtney, Appleby, Nurse Shanika, Dancing Nurse. I guess probably all of these are on live or something. Yeah. But that's just it. But go over to my page and subscribe and follow. Don't be inactive. Even though I really appreciate you guys coming over here. Just like how I see you guys up there and you're not making the hearts come up. Yes, you're not liking the video. I really do appreciate you taking the time out. But I really would love for you to be active on my page. Ask questions so I can answer, because I know a lot of have questions that needs an answer related to nursing, travel, and lifestyle. All right. And you're just listening and not asking the question. Probably you're waiting for somebody else to ask, and then, whatever it is. But definitely go over there and subscribe to my page and follow me there. And, and that's it. And this video, I will definitely post it on my YT page. It's going to be very long, I think. It's going to be very long. I'll post it there. You can watch it just in case you're coming and you miss something. All right. But anyways, any questions before I go? Hi, Ishmael. Welcome, welcome. All right. Well, I'm going to go wash my face and do 3 notes before I go to my bed. What time is it? 11:43. Yeah, that's what I said I was going to do. I was going to do 3 notes, and then tomorrow I would have done the other 3. But I decided to come on live. And then from there. All right, so I will see you guys in another live. Remember to go ahead and follow me if you haven't followed us yet. User 127 with a bunch of numbers, welcome. You're a little bit late. Dade County KK, welcome. Maureen Gordon. All right, yeah, so I'm gonna go, and then I will see you guys in another video. All right, probably you see me and my hair probably pulling down, because I plan on pulling down my locks. Yeah, this is probably like what, 2.5 months now, going 3 months. I think it's time for me to look new again. Yeah, so I'm gonna pull down my locks tomorrow. Probably. Yeah, if I'm not sleeping the entire day. All right. But anyways, I will see you guys in another video. Thank you guys for tuning in. I see 14 people here. It was nice, chit-chatting with you guys. I will see you in another video. All right. Enjoy your night.